Welcome. Glad to have you here. And I would love to just take a moment and say thank you all for being a part of such an important meeting, especially given funding cuts and such, making it difficult for folks to travel. I know that Mike and Jerry and I really wanted to be sensitive to that this year and be sure to make it a virtual meeting. So with that in mind, welcome to the 13th International Virtual Conference on Academic Detailing. This year's theme is Integrity in Action, Committing to Evidence and Empathy. We're so excited to say hello from our home team, as we call it. And we also have our extended team here with us of facilitators. I see you all in the audience.
We're on tomorrow at noon.
Okay. Oh, and let's just make sure we're on mute if we're in the audience. All right, so kicking off, you all know me. I'm Bevan Amira, the Deputy Director. So excited about the program we have to share with you over the next few days. You'll hear quite a bit from me, so I'll take a pause now and turn it over to one of our fearless leaders and our founder and director, Dr. Mike Fisher. Mike, good morning.
Good morning, and good morning, everybody. Everybody on the call. It is on the conference. It is really great to see you. As Bevan said, we just felt like it was so important to have a space for all of us to gather. And as great as it's been the last couple of years to reconnect in person after our virtual years of the pandemic, we did learn, and by we, I mostly mean Bevan and Anna and the people who really make it happen, how to put on a great virtual conference. And with the challenges that everybody's been facing, we decided to prioritize having a venue where we all could come together in community. So thank you for being a part of that. We're really looking forward to using this virtual space to be together and to connect in the same ways that we've been doing in person.
Thanks, Mike. Over to Jerry, our co-founder and special advisor, and of course, the godfather of AD. Jerry, how is it going this morning?
Good morning, everybody. It is so good to see so many familiar and not yet familiar faces, and to thank you for all coming together, and to thank Bevan and the team for making this happen. We are hoping that next year we will actually be able to be in person if possible, as well as virtual, but for now it is very good, especially in these crazy difficult times, to see so many old and new friends to talk about this really important stuff. Welcome.
Thank you, Jerry. And on behalf of Anna Morgan Barsamian, our Senior Manager of Training and Education, who many of you know so well and who has been a vital part of our team these past 6 years, she's returning from maternity leave in just a few weeks and asked me to extend her hello this morning and her enthusiasm. And I know she will be very excited to catch up on the recording. So welcome from our home team. Now, in that link I popped in the chat, you can access everything you need. The entire program book is there. So please take a moment, learn about our presenters. We'll walk you through the agenda for the day. And if you care to share your thoughts on social media, please holler at us with @NaRCAD or use hashtags NaRCAD2025 or academic detailing. If you haven't had a chance to check out our program book yet, we have our featured blog this year, which is a piece by Dr. Avorn that will also be a bit of a preview about what he'll speak about tomorrow during his annual AD talk. So highly encourage you to check that out. You can find that again on page 17 of our program book. And I'm also going to drop it right in the chat where you can check it out right on our blog. So if you have a free moment to check that out, highly recommend some fantastic thoughts from Jerry that he will follow up on tomorrow. After the event, you will have all of the recordings with the exception of the breakouts. You will be able to check out the entire slide deck. There will be a transcribed version of all of this good stuff. So don't worry if you forgot to write something down. Also, I will be collecting every link that is dropped in the chat box over the next 2 days. So there's something you're looking for, we will have it ready to send out to you in a post-event blast. But first, I want to say an enormous thank you to our incredible sponsor, Alosa Health, our very good friends with whom we have shared office space, ideas, and of course, the intimacy of knowing this field so well. So I'd love to say a quick hello to everyone here from Alosa Health. Thank you so much. And thank you, Jerry and Paul in particular, for making this possible. We're so grateful for our long-term partnership and highly recommend that you all visit the experts, alosahealth.org. All of the wonderful evidence reviews they do are just incredible and really deserve a moment to peruse through their gallery of the hard work they've been doing since 2003. All right, so let's talk about what's in store for today. We're in the middle of our kickoff. Shortly, you will see day one opening remarks and audience reflections. Anything that you want to share during our chat waterfalls are things that we want to hear. So Mike will be kicking that off shortly. We will also have day one field presentations today. AD leaders across North America will be sharing their thoughts from the RX files, sharing about reimagining resources in collaboration with patients, to the San Francisco Department of Public Health Chow Center talking about direct-to-patient advertising, and our friend Amy McWeeny up from New Hampshire's Department of Health and Human Services talking about how do you detail within your capacity, the never-ending question. We'll have a break at 1 o'clock Eastern, followed by a speaker spotlight. Nadezhda Razi-Robertson from Synergy will talk about trauma-informed detailing, after which we'll have a transitional moment and get into afternoon breakouts. Today's theme is Creative Foundations for Stronger AD Programs, where those of you who are brand new will have the option to check out AD 101. You'll also have the option to learn from Narissa and Rucha of University of Illinois at Chicago's Illinois Advanced Program about how to have lasting connection beyond just the one-to-one visit. And of course, you'll have a chance to learn a different approach to building a program. Voices into Action will focus on how do you bring that patient voice in at the ground level. So you'll have an option to check that out, and you can grab all of the links right from the chat box just prior to breakouts. You'll come on back for a break, and then we will wrap up the day with featured presentations on clinical diversity. We'll be looking at AD for obesity management rooted in empathy, really looking at anti-stigma, focus on supporting patients who are obese. And then we will have a fantastic group also talking about dementia educational techniques for clinicians. And we'll wrap up with plenty of time to debrief and do a quick eval and say thank you and good night. So that is the day. Whenever you see a slide that looks like this, it means head on over to the chat and throw your questions in the box. You can, of course, put those in during a presentation, and I will keep an eye on that and triage those to whomever is presenting at the end of their session. And those of you who are familiar with us know we love our chat waterfall questions. So when you see a slide that looks like this, it means you'll see a question on the right that you'll head on over to your chat box and type an answer to. So let's kick it off with a couple examples before we head into opening remarks. All right, here's just a nice light, loose one. What's your favorite part of fall, of the season of fall? And of course, it depends where you are across the globe right now. But Erin's kicking us off with crisp weather, the colors, anything pumpkin spice, changing leaves, more for leaves, going to the beach, because Alexandria is in Florida. Cooler temps, sweater weather, pumpkin patches, football, bonfires. We love it. Boot weather, apple picking, Thanksgiving, birding, fireplaces. We love a good bowl of soup, smoking up some meats, cider, allergies getting better. I hear you, Donetta. and comfy clothing. Keep it coming, but those are all the things that we get to enjoy, including spooky season, which never ends after the 31st of October. You can be spooky anytime you want. All right, let's try this one. Describe detailing in one word. That will be your challenge. What do you think? Communication, fun, rewarding, relationships, connection, impactful, conversation, informative. Lots of duplicates here for conversation and relationships. We also have partnership, outcomes, engaging, influence, pragmatic. I knew that was you, Mike. Empathy, resourceful, timely, educational, networking, and preemptive. Ooh, we love that one. All right, thank you guys. And one more. This one's a little more serious than talking about the fall. The biggest threat to public health right now is blank. Fill in that blank. Aaron says this administration, lies, funding, misinformation, the government, Donald Trump, misinformation, incorrect information, social media talking about what medicine is, stigma, influencers, a lot for misinformation, losing the focus on evidence. Yes, Trish from Canada, we agree. A lot of people are saying ditto. So we have a sense of what is in the way here. And luckily, we are going to move into a really wonderful opening talk where we'll talk a little bit more about what to do with some of these barriers. A few more here. Misblame, being bad at assessing the evidence, and a lack of understanding of the work or the benefit of our work. All right. Well, Mike, you've got a lot to talk about, and I know that some of it will hit on this. So I'm really pleased to introduce our founder and director, Mike Fisher. I know many of you know him, but for those of you that don't, he steers the ship that is known as NaRCAD and does so beautifully. And I'm sure you will find a little bit of solace and hope in the words that are to come. So over to Mike to lead us into a talk called The Way Forward, AD Alliances in a Changed World. Mike, over to you.
Thank you, Bevan, and thanks everybody for those fun chat. Well, the last one more sobering, but the chat waterfalls. It's great to see how engaged and enthusiastic we all are. Bevan emphasized how important it is to all of us to stay connected in this virtual space. And I really want to use that as a jumping off point in what I'm going to talk about today, to reflect on how all of us can collaborate, how we can stay connected, to support each other, to really work as allies who are trying to find a way forward for our field, trying to build on the shared sense of purpose that we have to accomplish the mission. You know, we just talked about, once we got over the fall weather things, those words about what academic detailing can embody: empathy, pragmatism, evidence, beneficial effects for patients, communities, everything around there. And we talked about, excuse me, and we talked about the challenges that all of us are facing. And I think that's critical for us to really acknowledge the environment that we're in. The thoughts and reflections that you shared in that chat waterfall, each of them, you know, has a slightly different valence, and I'm sure most of us could put several items in there. And you know, those reflect valid issues that all of us are grappling with. The purpose here today is not to say, oh, don't worry about that. Those are real concerns. They're worrying all of us in the world, you know, who think about public health, who think about health on the individual patient level, you know, at a larger societal level as well, which touches all of us in many aspects of our lives. But of course, we're coming together because of our shared interest in academic detailing. And as an academic detailing community, these are legitimate issues for us to be worried about. These are real threats to the work that we do. You know, over the last, I guess it's almost 10 months now of this calendar year, the environment in which we are pursuing evidence-based medicine, in which we're trying to improve the health of patients, populations, and communities, has become more difficult, both structurally and in many cases an outright hostility to some of the core principles of our work, as well as to specific individuals or communities or the topics that are critical to their health and well-being. There are a few different elements of what we've lost when we think about what's happened there. You know, one element is trust in sort of aggregating groups. You know, how do we think about the the organizations that have put together the evidence that we've been able to trust over time? So, for example, there'll be a session later in the conference from our colleague Jackie Travers in Oklahoma, talking about how we rely on evidence when the changes that we see at the CDC may mean we can't trust them as an aggregator in the way that we used to. We also need to realize that what's happened to date isn't necessarily the end of what's happening, unfortunately. There are structures that may continue to be dismantled. So, you know, one of the latest threats in academic detailing, especially for chronic diseases, but really for a range of conditions, we've often relied on the U.S. Preventive Services Task Force, which is a remarkable group, all volunteers, by the way, with an extremely rigorous vetting process to ensure that they don't have conflicts of interest, who diligently review the best evidence, as I said, on an entirely volunteer basis, and provide guidance that is phenomenally helpful. You know, when I think about the part of my life where I'm still a primary care physician, incredibly high reliability input. But there have been proposals floated to dismiss the members, to replace them with some who are, I believe the expression in some of the news stories has been less woke, sort of using air quotes for any of you who are listening and not looking. And that's concerning. All of us who care about this, all of us who rely on sources like the USPSTF to try to promote evidence-based practice, need to figure out how to work together to continue making a difference for patients. Jerry spoke about this in his blog piece, wrote about this in his blog piece, sorry, and we'll be speaking about tomorrow some of the questions of where data comes from, how we think about it. I'm going to make a couple of comments on that today, but it won't be the focus of what I'm going to say. But I want you to think about them together. It's really, how do we think about where the evidence comes from, and how do we think about using it? We have to recognize that there are topics where we're going to be constrained. Gender affirming care has become a topic that we can't talk about, although last year and in prior years, we've had some really great presentations at our conference about it. And I don't mean that we can't talk about it, but I mean that sort of in the government-funded space, it has fallen into disfavor. What is sort of off limits in terms of talking about diversity, in terms of, for example, one of the things the USPSTF was targeted for was their finding that PrEP, pre-exposure prophylaxis for HIV, is a level A recommendation, which of course we all know it is. Those are very threatening to many of the patients and populations we try to serve. There's also an effect on volume. As the systems are being dismantled, there simply will be less research coming out. If the cuts to NIH are as bad as they could be, we may simply have less to draw on. All of this can be discouraging, and it's important to take a moment to acknowledge those feelings, to be together, to share that. But I don't want this to be a message of despair. We have to acknowledge that there is hard work ahead of us. We have to acknowledge that we face problems. But I think there is still good evidence out there. There is still diligent research being done. The people who we would look to for how to do a good study, how to help review a good study and critique it, and maybe put together and say, here are 4 studies that are good, 2 that are less reliable. We're going to synthesize that. We're going to help tell clinicians what to do. Those people, those are our people. They have not disappeared from the earth. They may be discouraged. They may be harder for them to get funding, but they are there. There are people doing good research, And the fact that it may be harder to identify that evidence because of the volume of misinformation, the fact that some of those people may produce less research than they would otherwise, which is a big loss, of course, for all of us, that doesn't mean we should stop. And it doesn't mean we are at ground zero or sort of at point zero. There is still work to do. And I would say that we as a community know how to do this. You know, identifying the best evidence has always taken work. Even though we would rely on aggregators like I talked about, the best academic detailing programs that many of the people here on the call and some of our colleagues who couldn't make it embody really put in the work to take those studies, those aggregated recommendations, and develop approaches iteratively to figure out how do we use those most effectively. On the whole, though, we were able to take the evidence as an input into our detailing work. We needed to do work, but we had the evidence as a reliable input. So we're going to need to think about how we navigate this changing evidentiary landscape. Jerry will be diving into that more deeply tomorrow. And again, people who've read his blog piece know that he, as he always does, will draw both on history and current events to give us the ideas and inspiration we need for that. But I want to highlight a little bit some of both the challenges and the opportunities for us for once we've identified the evidence, how we go out and deliver it. We are a community that's skilled at innovation and adaptation, and we need to keep collaborating and sharing ideas about how to deliver the evidence. We don't want to be dragged down into sort of be impaired by the problems with misinformation so that we lose hope, because innovative communication techniques, innovative outreach has been one of the strengths of NaRCAD. Indeed, one of the reasons we created this conference, I guess this is our 13th, so 13 years ago. For example, elements like virtual detailing were small sessions at this conference, 10, 12 years ago, started to increase 7 or 8 years ago. They're now part of every detailer's toolkit. So my suggestion to you as we try to think about a way forward is that our shared task and what we can continue to build together through this conference and beyond is that work of identifying the best evidence, preserving the principles of evidence-based medicine, and also to continue to create new ways, new means of reaching clinicians, engaging with them, helping them to understand how the evidence can help their patients, even if identifying that evidence is harder than it used to be. Our mission doesn't change. Now, that's a lot to do. That is a tall order, and maybe it's a taller order than it was a year ago. But I know that all of us didn't go into this work because it was the easiest thing to do. We went into it because we are up to that challenge, because we believe in what we're doing. And so for the rest of my introductory remarks, I want to highlight some ideas about how we succeed in this work. So I want to frame a couple of sort of high-level questions and then suggest some directions we can go in together. First, how do we continue to meet the goals of AD? The things going back to what Jerry defined 40 plus years ago, what NaRCAD has been here for the last 15 years, what each of you in your programs and organizations are working on. How do we meet those goals, but while maybe having to adapt our methods? How can we identify maybe new structures and supports? Much like is happening in the larger landscape, there may be some things where we have to protect and rebuild things that are being taken away or destroyed, and places where we have to build new structures to do our work. Think about different approaches. And to do all of that, how do we strengthen our current network of allies? How do we both consolidate the relationships that we have and build new partnerships? I want to suggest a few thoughts about how we start doing that together. I would say that as we start looking at the path forward, we really need to mentally center the communities that we're a part of, the ways that those networks, the allies that we work with across a range of domains, can make a difference alongside us and in partnership with us. There are others who do this kind of work as well. Academic detailing is not the only community that focuses on the importance of evidence-based medicine. I mean, we're obviously the most awesome community that focuses on evidence-based medicine, but there are many others out there who think about these principles and how to apply them. And that cuts across a range of sort of types of affiliation that we can take care of. So I'd suggest that as we try to identify the path forward, we want to be intentional about building on those. So I'm going to pause and throw it to Bevan for a new chat waterfall to start that process, thinking with you about who are those allies when you think about bringing the evidence to the front lines is important to me. Who are my allies when I'm trying to do that?
Thanks, Mike. Okay, so pop on over to the chat. Fill in this blank. My allies and community members in this work of improving patient care include whatever comes to your mind. Don't overthink it. But we're going to kind of try to map who we can connect with and think about, multifactorial approaches, think about new partnerships, think about partnerships that might be there but need a little reinvigoration or some TLC. So pop on over to the chat and fill this in. All right. Thank you so much, Donetta. Community-based organizations, patients, family members, state organizations, physician champions, health departments, community centers, libraries, churches, peers, community anchors, our state opioid response team, specialty societies, AAFP, AAP, ACOG, pharmacists, the patients themselves, universities, residency programs, my team members, experts in the field, subject matter experts, colleges, medical schools, state and local organizations, peer support specialists, faith-based community organizations, professional healthcare colleges, educators, treatment centers, systematic reviewers, C-suite folks could be a big part of it too. Keep those coming, but these are all fantastic suggestions. Healthcare champions in leadership, people with lived experience, 100%, coworkers for networking and plugging, providers, patients, and caregivers. That seems like a wonderful place to pause, but keep them coming for folks to be thinking about. And back to you, Mike.
Yeah, that was, thank you all for that. Those were really a beautiful set of ideas and reflections. This is something in over the course of this year and in the run up to this conference, I've been thinking about a lot for this work. And, in thinking about who else cares about the work we do, who dedicates their time and skill to it, there are many domains. I think actually I'm so glad that, as Bevan said, we will be saving the chat and it will be available, because I know the beauty of this community is I know there are ideas in there that we didn't have in preparing the talk. But since we did have to prepare the slides ahead of time, I'm going to say that these domains, do each offer chances to collaborate, and each of them can give you some practical ways to move on from sort of the discouragement and to reach out and to draw on those connections, those alliances to collaborate. The three domains I'm going to talk about are around geographic, interdisciplinary, and organizational diversity. And as I said, there are probably, if I could give this talk again in a week, I'd probably draw in more domains that you suggested. But let me give you these three as food for thought, and then we'll sort of build on that, hopefully together, as we continue to think together. So, in thinking about geographic diversity, in some ways that can especially come to mind because we are doing a virtual convening this year. And that reminds us that although there are real problems, we are based here in the United States, and our focus is in the US, and some of the more acute political changes have hit our domestic programs. The challenges of misinformation and what that does to public health are global. We have many of our treasured colleagues from Canada here today, and unfortunately this week Canada lost its status as a country that has, I'm missing the exact infectious disease terminology, but that has eradicated measles, because the measles rates are back in Canada. So it's not just here in the US that we struggle with this. Our presenters are from across the US and Canada, as we saw in the logins. We have folks here from Brazil, from Australia, colleagues from across the world who've been with us and have presented in past years. And each of us in our region has connections, and are part of unique collaborations, drawing on the different ways in which healthcare is structured and delivered in these settings. And perhaps especially in challenging times, one can find alliances within your region that might not have been possible before. I'll say I know we have a few people here in addition to our NaRCAD home team from the Boston area. There have been a few healthcare related advocacy issues over the last several months where some of the Boston-based teaching hospitals have been advocating together. And I see Jerry on my screen. He knows they don't always like to play nicely together, but sometimes you can find allies for a really important purpose in your region. We want to, and then of course you can collaborate across regions. We want to share ideas about what can you do to create regional alliances? How can we form collaborations that maybe fill in some of the gaps as the structures that we had counted on are more challenged? The next area I want to introduce really goes to the core of academic detailing is diversity across disciplines. AD is at its core an interdisciplinary endeavor. It goes back to the very first studies where, obviously everybody knows, Jerry's a physician, there were pharmacists involved, there were nurses involved. I mean, from the very first, in the sort of research environment for AD, and it's only become more diverse over the years. So because of that interdisciplinary nature, each of us is part of multiple networks and works with a range of colleagues and allied organizations. So, I mean, just to call out, on our agenda, we have, I mentioned nurses, pharmacists, physicians, but we have people from research backgrounds, public health, people who focus on medical education, many, many others. And in each of those disciplines, you may have either colleagues, whether they're from when you were getting your education, from wherever you do your day-to-day work, because many of us who do academic detailing also wear a lot of other hats and have a lot of other connections. Whether they are through a more formal professional organization, I think I saw on the chat waterfall, people talking about organizations like physician societies, nursing societies, pharmacies, public health organizations, and so on. Each of those groups cares about maintaining high standards in their field. They have a mission to which they are committed to staying true. That sort of collaboration, whether it's peer navigation, patient engagement, any of the related fields, can be connections that we can build on, where we can identify innovative ways to move forward and also sources of support, which is not unimportant as we are taking on that hard work. The other dimension of diversity that I want to talk about is organizational. And again, you'll see in the presenters and folks who are on the call from across our NaRCAD network, people work in sort of large integrated healthcare systems, for small nonprofits, for state or local government. I think with the way things have shaken out, unfortunately, none of our federal colleagues were able to join us, but there is great work going on and that people are working hard. I think of often these days of our colleagues in the VA's academic detailing program, who have been regulars at our conference and do amazing work, but it's a much more challenging environment. Coalitions, I talked about professional organizations, all of those different kinds of organizations will have different responses. And this is not to be Pollyanna-ish, not every large organization, and again, I'm talking about the US context and the threats we're seeing here now, in what we've seen in the US the last several months, not every large organization has distinguished itself in standing up for its principles or the choices that are made. But there are a lot that have, and continuing to look for that, to advocate where we can as members of those organizations, to create those alliances and those networks where we can find how can we keep the work of academic detailing going, maybe with different organizational structures, different kinds of organizational collaborations. As I said, if I were fast enough with the scanning, I suspect you all have put in a couple of other dimensions of sort of our diverse networks and set of allies that we could reflect on as well. And I hope that we'll all do that afterwards. But I know I'm coming to to the end of this time. And so I want to reflect a little about where we are today and where we're going tomorrow, so that we continue to be looking towards the future, that, that we've created hopefully this space that all of us in the community can see that we can get excited about what we're doing. We can say that over these 2 days that we're together here and really beyond, as we stay connected with each other, that we can build on the breadth of experience, the wide expertise, and the energy that everyone in this community has to create new connections, whether that's connecting with longtime colleagues, maybe those who are on the call here, the conference here, or people who do similar work who maybe you haven't reached out to in a while, and you realize in these difficult times we need to find the allies we can, to think about where are there new collaborations, where are there new alliances that can keep our critical work going. So my goal, my hope, my challenge to each of us is to take what we learn in the next 2 days and to move forward, to work together, to think about what are those new structures, what new resources do we need, and how do we start to build them in a way that doesn't just sustain our field. And to be clear, sustaining our field is incredibly important. We've built something really special in this community. We talk about it every year because it's one of the purposes, from a first paper 40 plus years ago to, a first conference in a small room over a limited amount of time to this large community. We need to sustain that. But our challenge is to move forward, to enrich it, to expand it, even in this environment. Even when it's hard, we don't give up. So, we do need to be realistic. I'm doing, I believe Bevan tells me, sometimes for the opening, it's important to tap into a little bit of the hype man, I think is the right term. And so, we are doing that because we do need to keep our spirits up and work hard. But that's not, we have to be realistic. All of us in AD are facing challenges. The field of healthcare as a whole is facing challenges, especially all of us who care about evidence-based medicine. And there are larger challenges in our society, as we all know all too well these days. But if you agree with me, the work is important and worthwhile, that what we have chosen to take on as a task is something that it is meaningful to do, that you can get up in the morning and feel good about being an academic detailer and working in this field, then the task for us is to figure out that path forward, to think over the next 2 days about how we work creatively, collaboratively, maybe try new and risky things while staying true to our mission of identifying the best evidence, translating it to action-oriented messaging, and delivering it to frontline communities. So in closing, I have faith in all of you as a community to continue to figure out what these new ideas and solutions will look like. Each of us has ideas, but I think as some recent developments, even in the political world, have shown us, it can't all be top down. This network, this community of allies, and the allies that each of you have in your region, in your organization, in your profession, in other domains, have the dedication, the talent, the integrity to create these solutions. So there'll be lots of opportunities over the next 2 days, but really over the entire year for this conference, or the summit next summer for next year's conference that, as Jerry said, we are hoping we will be able to be in person, to engage with your peers, to make new connections. All of us on the NaRCAD team want to go alongside you on that journey. And we want to get started today and tomorrow by thinking together about where we can go, how we can move forward, even when it's hard to do so. So thank you for being here. And I'm excited to hand it back to Bevan to start transitioning us into all of our wonderful and diverse group of presenters.
Thank you so much, Mike. And again, for those of you who know you have colleagues who may be missing out on today, Mike's talk and the rest of the main sessions are all going to be recorded, including this upcoming one that I am particularly excited about. We are calling it AD Leaders Across North America Innovative Program Planning. And all three of these presenters are really here to show you how it's done creatively, and give you some ideas that you can take back to your program. And one thing I do want to say as I introduce this grouping and then turn it over to Mike to do individual introductions is, whether we have a Canadian group presenting, whether we have someone from the VA, whether we have someone presenting about a specific clinical topic, the goal of every presenter and of our conference is to find those translatable nuggets. So please don't think, hey, this is about dementia, so this won't apply to my program. I guarantee you that the approaches shared, the creativity, the ways in which folks are building new structures, new approaches, doing program planning, are all going to be relevant to the work that you're doing. So over to Mike to kick us off for our very first field presentation of the conference from the RX files. What a duo we have for you. Over to you, Mike.
Absolutely. Yeah. Our first presentation is, when you talk about NaRCAD allies, there's really the RX Files team is one of the longest standing NaRCAD allies. Of course, RX Files was around even before we were. And we have two outstanding members of that team who will be taking the virtual podium in just a minute. So first up is Debbie Bunka. She draws on her early work in hospital pharmacy. She led an AD service in Calgary, and she's been with RX Files since 2010. So for 15 years, actually, that parallels exactly NaRCAD. We were founded in 2010 and are in our 15th year. So we're really fortunate that she'll be sharing that wealth of experience with us today. She's had a particular interest in her clinical work in long-term care. She had some of her time with RX Files was in their specific Jerry RX Files program. She's joined today by Tahira McAleer. Tahira got her initial practical experience in retail pharmacies in rural settings, so really out on the front lines, and then joined RX Files first as a contract academic detailer back in 2018, and then later expanded to providing detailer and information support for the team, which she's been doing for the past several years. And the two of them will be presenting from oversight to insight, reimagining resources in collaboration with patients. So Debbie and Tahira, over to you.
Thank you so much, Mike. Hello, everyone. Tahira and I are so glad to be here with all of you. The theme of this conference really captures what we feel academic detail is about: staying true to the evidence while also staying very deeply connected to the people that we serve. In our session, we're going to be reflecting with transparency on some of our program's missteps, because integrity isn't about being perfect. At the heart of what Tahira and I will share is the simple but the powerful act of listening to patients. They were the superstars in the recreation of some of our patient-facing tools. So again, my name is Debbie Bunka, and I'm an academic detailer with RX Files. I work part-time as a pharmacist in a primary care clinic, and I reside in Regina, Saskatchewan, Canada. I do not have any personal conflicts of interest to disclose. Tahira and I in this picture, we're proudly wearing our Rough Rider greens because our beloved football team is headed into the championship weekend.
Yes, go Rough Riders. It is the Super Bowl of Canada coming up this weekend. And Aaron has already called us out in the chat, Debbie, that although we're not declaring biases, we are biased for our football team up here. My name is Tahira McAleer, and I'm also a pharmacist and academic detailer with the RX Files. I additionally do casual work as a relief pharmacist in community now, and I dabble in rural primary care setting here in Rosetown, Saskatchewan. And I also don't have any work conflicts of interest to disclose.
And Debbie, I did mute you for a second just for feedback going back and forth. So if you can mute when you're not speaking, I think we'll do great. And we have someone saying you look like twins. So hey, same energy.
There you go.
All right, back to you.
Thank you. Tahira tapped me on the shoulder a while ago, asking her if I would co-present with her, and I was eager to help out, always willing to give back to this passionate community. But I have to admit that I was a little hesitant to position our program as leaders in this area of patient engagement.
So Debbie and I decided that maybe our scenic detour could be helpful for those trying to make this same leap. We're trying to share our story with a bit of humility and hopefully a little bit of humor because it definitely hasn't been a straight path. And really, that's what this session is about, staying grounded in both evidence and empathy, even when the road takes some unexpected turns.
As mentioned, I've been a friend of, collaborator with RX Files for many years. When Lauren helped us to this timeline for today, even I was really surprised to learn the very first patient tool was created back in 1999, just 2 years after our program's inception. And as our program expanded from a local pilot project to a provincial service, our patient tools evolved as well. And it was around 2015 or so that I started to help out with the graphic design of these patient tools. And in 2018, when our program physically moved into the university setting, we really started to create a lot more. We were offering patient booklets, leaflets, clinic posters, and tearaway handouts for clinicians to have conversations with their patients on a variety of medical conditions. Thank you. When RX Files first began, our focus was squarely on supporting clinicians. Our tools, especially our drug comparison charts, if you're familiar with those, and our academic detailing resources, they were really built to reinforce the key messages during our educational outreach visits. Patient-facing materials were not our primary focus. They did surface occasionally, and this was usually in response to clinician requests, or if we think back to our FBBE, our features, benefits, barriers, and enablers, we were creating patient tools as enablers to some of the barriers that we were working through during our topic development. Most of our early patient tools were not meant to stand alone, meaning that they were designed to support but not replace conversations. Around 2010 is when there was a broader movement that was taking place across healthcare settings. So the patient perspective was gaining traction, but if we're being honest, we were a little late to this table. While others around us were embedding patient voices into their work, RX Files, we remained focused on tools for clinicians without the patient perspective being in. And this was regardless of the fact that the patient was the end user of these products. Now, it wasn't resistance to this idea of the voice that held us back. It really was inertia. So time, practicality, value constraints have meant that the patient voice hasn't always been fully represented. Our patient-facing tools have evolved gradually, shaped by clinician needs, institutional shifts, and a growing movement toward patient-centered care. Next slide, please. As RX Files transitioned to the University of Saskatchewan, we saw new opportunities. There was a growing budget, who doesn't love that, a different leadership structure, and changes in personnel. All of those things really opened the door to rethinking our approach. So interest in patient-facing tools started to grow, not just from clinicians, but also from within our organization itself. Thankfully, we had change champions along the way. Those are the people who nudged us, they questioned us, they reminded us that if patients truly are central to care, then they should be central to our materials as well. We had leadership willing to invest time and resources, and we had moments of internal reflection while we were able to review our organization's vision, mission, and values, and it was really clear. Including the patient voice wasn't just considered strategy. We all agreed that it was the right thing to do.
Thanks, Debbie, to guiding us to the point where action began for us. We launched our official patient review process at the start of 2025, and we kicked it off with 2 lipid-focused tools, one to explore statin use and myths, and the other to address muscle aches and re-challenging strategies. We started from scratch. No patient participants, no process, and no experience. And our biggest question was, how are we going to do this? We tried what felt like everything, knocking on doors, not literally, but a family of friends, pharmacies, clinics, making clinician handouts, and even asking patients during our own clinical shifts within our team. We posted on government patient engagement research sites, but the audience was niche and restricted to a small pool of patients. We also discussed honorariums and how to feasibly do that. We wrestled with how to make participation inclusive and accessible. And eventually, we landed on a multi-model approach. So we offered online surveys with the options to print out these surveys, mail them out, provide a stamp so they can be mailed back to us, offering telephone sessions if that was easier for some patients. After hours of prep and outreach and coordination, we had a whopping N of 4. So, would love to turn it to Bevan for our chat waterfall so you guys can help us discuss what barriers you may have encountered when trying to get some patient engagement.
All right, so whether you've done this before or just thinking theoretically, what do you think the biggest hurdles are in trying to engage patients in the process of building tools? So pop some potential barriers in the chat. Why was there N only 4? Another way to think about this question is what stands in the way of engaging patients in helping build a detailing campaign? All right, so let's check out the chat box. Buy-in, stigma, right? Patients may feel like they're going to be stigmatized if they share their thoughts. Another one on getting patients to see the importance. Someone else might say, my doctor decides those things. Katie Mack says, sometimes we as program developers stand in the way. Maybe no incentive, right? So getting gift cards out there, ensuring that there's a diverse group of patients can be difficult. Peggy brings up an important point: patient comprehension, health literacy levels. Some more for stigma and importance. Mike says our health systems haven't been well designed for these kinds of connections. So integrating patients just isn't something that's built into the structure. Large hospital systems cornering the market, right? Making it hard to get in the door and access the bulk of patients in the community. Fear, figuring out how to do it. And then figuring out whether the patients who sign up represent the average patient. So great thoughts here. Thank you so much. And back to Debbie and Tahira.
Oh man, this team just hit it right on the head here. Those were definitely some common barriers. And I think I heard you say, Bevan, that somebody had wrote in the chat something about a patient saying that, oh, my doctor decides this for me. And
Yep.
when I reached out to a patient in retail pharmacy, that is exactly what I heard back is, oh no, I just do what my doctor says. So I don't want to contribute to this. So you guys took it right out of my head. At the end of the day, we really weren't powered enough and we were running into big barriers. Financially, things weren't adding up when we look at the hours that we were investing. They far outweighed what we were getting back with our N of 4. We struggled to find patients, let alone a large enough pool to reduce bias and ensure that diverse representation. And we also ran into rigid university policies around honorarium payments. We were only allowed to offer direct deposit, which meant asking patients for banking information just to receive $25, which naturally put up some red flags for patients. And some patients don't even have banking information to provide. Understandably, that was intimidating for many people. Checks weren't allowed, gift cards were limited to $5, and we just didn't have any flexibility within our university program. Next slide, please. So during a carpool ride I had driving to the university with my cousin, I was airing out all of these frustrations and these barriers we were hitting. I was annoyed that couldn't find any participation. It felt next to impossible. Paying honorariums was a bureaucratic maze, and he offered help. I had been carpooling with this lovely gentleman for years, And turns out a solution was sitting right next to me the entire time. My cousin works for Chaser, the Canadian hub for applied and social research based right at the University of Saskatchewan. And their whole job is helping people navigate research. They offer consultation services for projects of all shapes and sizes. They've got massive pools of participants ready to go. They collect data, they process it, they analyze it, and they wrap it in a bow and hand you this beautiful report. I don't know how I didn't see this the whole time. I guess all this time I thought that this program was for larger research projects and surveys, and I had overlooked our program as an option for them. So it was kind of like unveiling this secret research superhero that was in the passenger seat the whole time. So we met with Chaser to talk through what we needed to meaningfully review patient materials. And through their consultation, they recommended focus groups as the most impactful approach. And just like that, some of the barriers started to melt away. They had it all. They had patients and people, they had methodology and the ability to easily pay honorariums. Where I could only do a direct deposit, they could e-transfer, they could hand over cash, they could do gift cards, they could do anything. All we had to do was bring our materials and our questions. And even then, they offered thoughtful feedback to help us refine those too. It felt like we had finally found the right partners to carry this work forward with a lot less red tape and more momentum too. So we went in for a second round of patient review. This time we tried this in the spring with our newly updated sick day management tool, with the attempt to make a universal one for patients with heart failure and diabetes. And this was to coincide with our kidney health topic that we were about to enroll. With Chaser's recommendations, we went for 2 focus groups with 18 participants each. We did not participate in the focus groups ourselves. Chaser facilitated the focus groups with semi-structured discussion, guided by RX Files curated questions. Each focus group met for about 70 minutes to assess the readability and the messaging of the content. And Debbie, would you like to share what we learned in our feedback?
So when we brought the patient-facing tool to the focus group, we absolutely expected constructive feedback, but what we received was a full-blown massacre. They did not hold back. They took a hacksaw to our carefully crafted content. They slashed through the jargon that we thought we had already worked through. They chopped off excess detail. They left no cluttered layout standing. So words and phrases, you can see them on the slide there, overwhelming, too much, pare it down. This came up again and again. It really was a beautiful work of deconstruction. They showed us exactly what needed to go, what needed to stay, and what truly helped comprehension and meaningful conversations. To be honest, the pages of feedback was harsh, necessary, but harsh. And the team, we weren't really actually too sure if this handout would actually even recover.
Yep, we had to really go back to ground zero with this one. So we had originally walked in with what we thought was a tool, and we walked out with a blueprint for something better, leaner, clearer, and truly patient-centered. The feedback from our focus group didn't just stop at too much, and you can see how we changed it based on their feedback on the right-hand side there. They urged us to take a stepwise approach, simplify the color scheme, use more clear, more purposeful graphics, and they gave us very specific suggestions for graphics even. And they caught that we were still using the acronym SADMANS on the back page. I thought we had taken it off, but we didn't. Oh, they did not miss that. They flagged language that felt vague or clinical. The key message, and this kind of stuck out for me, the key message that we thought we were delivering was strategies to protect kidneys when a patient is dehydrated. And what the focus group thought the key message was in that original material was to prevent dehydration in general. So our main message wasn't even getting across. and that was a very humbling moment. They reminded us that even well-intentioned tools can miss the mark as to ask, will this make sense to the patient holding it? And to take one step further, can we confirm if it does make sense when they do hold it, as opposed to guessing? Their feedback reshaped not just the tool, but our understanding of what clarity and relevance truly mean. With that insight, we're now looking ahead toward a future that's more responsive, inclusive, and patient-centered.
So no surprises here, but unfortunately, we do not have the budget that is needed to be able to review all of our previously published materials. Our goal is for all future materials to be patient reviewed through focus groups or something similar. Our leadership has also expressed an opportunity to reinvest any excess funds into the patient review process, should we find ourselves in such a favorable position. And we haven't even scratched the surface when it comes to engaging with underserved populations and overcoming maybe some of the unique hurdles to acquire their much needed input. And lastly, we want to collaborate with those who know how to do this important work. And so if this is you in our community, please reach out and start a conversation with us because we want to learn more.
Absolutely. And we are still looking for more patients from various populations. If we could offer any piece of advice today, it would simply be don't do what we did, at least in the terms of delaying including the patient voice. We published a range of patient-facing materials before meaningfully incorporating the patient perspective. And to this day, we're not confident in their usefulness from that lens. So if we could go back, here are some things that we would have considered sooner.
Pause, ask why the patient voice isn't present, and then actively start to explore how to bring it in earlier.
Question our assumptions. We relied on clinician feedback to validate our tools, and they weren't our end users. The realization forced us to reevaluate our feedback sources and rethink our entire development process.
And lastly, stay the course. As at many points for us throughout this process, years felt overwhelming. Like, why are we doing this? But a single candid conversation about those challenges opened that door to a solution. So keep talking. You never know which conversation will shift that thinking or spark that next step. We're 2 cycles in to patient review, and the momentum is building for us. RX Files is very in this patient-centered journey, but our commitment to learning is already shaping what's going to come next for our program. So thank you for your attention today.
Thank you both so much. So wonderful to have you both present together, share such an important topic that is really, really gaining traction in our field. I know that the crew from Iowa talked about this, and we'll be talking about it in more detail in a breakout this afternoon. So really just phenomenal to be thinking about. Of course, if patients are the end user, why aren't we incorporating their perspectives sooner? So please add questions to the chat box. We have 5 minutes for you to chat with Tahira and Debbie. Please, anything you want to share, you can also do the raise hand function, but since there are 90 people, I may miss it. So you are also welcome to unmute yourself. And we have some thoughts in the chat as well. Christine Fishman from Ohio is saying the voice of the customer really is incredibly important. That is one way to look at it, right? And so being ready for that harsh feedback. We had a nice reflection from Mike. Your experience embodies a key lesson that I have learned from colleagues with expertise in patient engagement. You have to be willing to be vulnerable and open to hearing patient feedback and critiques. All right, we've got a great question from Rebecca Martinez. How did you recruit for the focus group, and how well attended was it? Tahira or Debbie? Yeah, Tahira, you're unmuted.
Yeah, so I think that's where I feel really lucky that we were able to partner with Chaser because they did all of that work and they took all of that stress from us. And they had 100% attendance. That being said, I don't think we're done quite yet with Chaser. And in the future, we're hoping to recruit more patients from diverse populations, acknowledging that even though they have a large pool of thousands of patients, they're probably not getting everybody that we want to hear from.
Mm. Any other suggestions about recruitment? Ways to get folks involved. Let's say somebody doesn't have a group like Chaser. Any other suggestions you might have for someone starting out small that doesn't have those sorts of connections?
I mean, we tried it all. So I think that's what you got to do. You got to try out what might work in your area, see what sticks to the wall. Because we tried surveys, we tried website recruitment, we tried just handing things to, lots of us are clinicians, and so we were recruiting our own patients to be able to
Sure.
bring it in. So whatever avenues you have, just try it and see what works.
Great. And we have two more questions that we can squeeze in before 12:10. Aaron is asking, and then I'll go to Mike, wondering if using Chaser gets more, quote, professional opinion patients. Are these sort of typical patients as opposed to the ones that are kind of more, I see the words really useful patients, but ones that may give you more substantive feedback?
Yeah, I think that there's going to be some bias in there a little bit, although they have a very large pool with a variety of ages and different careers, and they're trying to mitigate their own bias in their own pool. I think that's still a factor that we need to consider as well too. And what I found was interesting too was that when we were doing our own recruitment, we were trying to find patients that would be taking statins or would be considering taking statins. We were kind of narrowing it down to patients who directly would be using that tool. Whereas Chaser couldn't do that. They couldn't say, oh, do you have chronic kidney disease? Or are you on medications that might have you at higher risk for acute kidney injury? So we didn't get that narrowed down to that specific field of patients. That being said, some of the feedback that we got directly, there's direct quotes from people saying, oh, this impacts my father, or I would like to share this information with my brother. So at the end of the day, there's still end user people that know somebody who would have used this material.
That's a great lens to think about. And quick reflection from Mike, and then we'll move on to our next field presenter. Thank you so much.
Yeah, I was just gonna, because it's so top of mind for me is from what I was talking about, that making alliances, sometimes your local hospital might have a patient family advisory council if you don't find an organization like Chaser, or there might be a community-based group that has a community advisory board. It's a great example of how to explore new alliances to broaden our work.
Thanks, Mike. Great reflections and great ideas. All these ideas need to be, we're going to flood each other with new ideas. Thank you so much to Tahira and Debbie. And now a chat waterfall to get ready for the next presentation. Fill in this blank. If I were creating a marketing flyer for a treatment or supportive service to patients, I'd make sure that flyer was blank. Choose 1 to 2 adjectives. And interestingly enough, this comes straight out of thinking about the RX Files presentation, but also moves right into our next presentation about direct-to-patient advertising. So we want these tools to be shiny, visually interesting, pleasure-focused, compliant, readable, font, color, simple but interesting, user-friendly, more graphics than words, short and sweet, clear and direct, simple and informative, clear and concise, clear and graphic, between a 5th and 8th grade reading level, accurate, engaging, focused, eye-catching, approved by patients, balanced with negative space and not designed by an academic physician, says Mike. Yes, and that is why Mike does not make slides. Attention getting, appropriate health literacy, attractive, brief, relatable, actionable, compelling story or graphic, engages the senses, and has a key message plainly stated. Well, these are a lot of things to think about. And so I'm going to turn it over to Mike to introduce our next presenter, Rebecca Martinez, who will be talking a lot about this very concept. Over to you, Mike.
Fabulous. Yes, Bevan and I have worked together for over 10 years now, and the only person happier than me that I don't make my own slides anymore is Bevan. All right. So this next up, we have a presentation from our colleagues at the Center for Academic Detailing on Opioids and Stimulants. They have the wonderful acronym of CHOW. They're based in San Francisco with the Department of Public Health. And speaking of allies, one of our really long-standing alliances, the first time our NaRCAD team ever went on the road was to visit the SFDPH in January of 2015. From CHOW joining us is Rebecca Martinez. Rebecca is a family nurse practitioner, and she brings that engaged clinical experience to her AD work. She works on the front lines in the office-based buprenorphine induction clinic with direct patient care. She's also in the San Francisco Department of Public Health Center on Substance Use and Health as a clinical trainer on opioid and stimulant-related topics, and the UCSF National Clinician Consultation Center, where she's a consultant on national PrEP and PEP topics. A great example of what I talked about before, about how each of us in this field is part of so many overlapping networks and wears so many hats. And we're thrilled that she's going to be presenting to us about direct-to-patient advertising in public health detailing. Rebecca, over to you.
Thanks, Mike and Bevan. You all can hear me?
Yeah, you sound great.
Okay. So hello from the Bay Area in California. I'm overdoing the theme of the Golden Gate Bridge on my intro slide and on my background. So yes, I'm a nurse practitioner, like I said, and we'll be talking with you all about a term that our team has coined direct-to-patient advertising in public health detailing. I've loved the work that the RX Files team has done for so many years, and it's so fun to get to sort of piggyback off of their really honestly beautiful, thoughtful reflections on doing this work with patients. And so would love to sort of continue that conversation as I present how our team has interacted with this topic. I have nothing to disclose. Bevan, you can go to the next slide. And yes, I'm representing CHOW, which stands for long acronym, Center for Innovative Academic Detailing on Opioids and Stimulants. We're associated with the San Francisco Department of Public Health, and we provide clinical education and technical assistance for any and all members of the healthcare team who care for people who use drugs in San Francisco. Very traditional detailing, if you will. And our original mandate was to help healthcare providers gain confidence about buprenorphine prescribing, but we expanded our scope to involve detailing on topics related to caring for people who use drugs in general, with a focus on opioids and stimulants. Since we know that in order to get folks to care about buprenorphine prescribing, we've got to even inspire more confidence around just caring for this population. So public health detailing, as we all know, has developed substantially over the past 2 decades, yet there's still so many challenges. It's downright hard for clinicians to prioritize public health interventions during busy schedules. Preventative interventions don't always have the largest evidence base. And sometimes there's a lack of pressure from patients to provide these services. In contrast, since pharmaceutical companies began direct-to-consumer advertising, drug sales have really soared. And clinicians are trained to be as responsible as possible to patient requests for medications. So while those of us in academic detailing, I think our gestalt is to really push back against the overuse of medications that result in wasted healthcare resources, our center, CHOW, sought to sort of leverage and repurpose the direct-to-consumer strategy. Oh, yes, this slide.
My apologies.
That's okay. To help patients ask for targeted public health interventions and specifically treatments for opioid and stimulant use disorders. So just like we've repurposed academic detailing from pharmaceutical detailing, we thought, let's try to repurpose this idea of direct to the person, or could be consumer, but we're calling it direct to patient advertising. Next slide. As part of our academic detailing work with healthcare teams in San Francisco starting early 2024, we realized that better patient-centered materials were needed to provide clinicians with new tools to support patients at various stages of change about their drug use. Speaking directly to patients in materials rather than to clinicians can achieve a double purpose. So it can both model to clinicians the language to use and the information to highlight, while also empowering patients with information about how to navigate their clinical interactions with their healthcare teams, which are so often fraught with I like the comment about people just say like, oh, whatever my doctor says, I'll do. But we really want patients to be empowered to say, no, this is what I need. You know, I heard about buprenorphine. What can you tell me about that? Because so many providers or healthcare workers might not necessarily bring it up. So we wanted patients to be able to think about what topics to think about themselves, what services to ask for, what choices they have as well. For example, like there's many ways to start buprenorphine. We want patients to know that. So we put together these 3 topics, which are on the bottom right of this slide. General health for people who use drugs, buprenorphine for opioid use disorder, and then topics around stimulant use, mainly healthcare interventions to reduce toxicity from stimulant use and just basics about stimulant use itself. Next slide. So we developed these patient-facing materials in extensive collaboration with an experienced graphic designer. We thought this was going to take a short time. It ended up being a 6-month iterative design process that was required to develop 3 patient-facing handouts. Most of the review efforts involved removing information that we had initially put on the handouts, less text, more visually engaging graphics, and several rounds of review involved laypersons and patients, as well as experts. Ultimately, we eliminated any charts due to difficulty interpreting their meaning for patients. We developed a simple 2-question sort of like algorithm for people to help them decide how they would consider starting buprenorphine. And we eliminated also sort of basic commonly provided information regarding how to live better when using drugs, like eat healthier, that were less relevant to interactions with a healthcare provider. And just to reflect for a moment on the RX Files experience, these handouts would not, I'm going to show the handouts in a minute, they would not have looked like what they look like without patients telling us what they wanted to see on a handout. Although I wish we had done a focus group. That's such a brilliant idea. We're like, how are we going to get our folks to come all at one specific time for a focus group? So I think that's one of our challenges is we're a drop-in clinic. We're a very low barrier clinic model. And so how to sort of equitably distribute the funds that we have, even if people aren't able to show up on time, that was sort of a challenge of ours. So once we developed, yeah, you can go to the next slide, Bevan. Once we put these together, we started distributing our materials to target clinics and clinicians. Here is what our buprenorphine flyer looks like. We designed it to engage patients with questions, sort of motivational interviewing inspired. The question on the first page is, what can bupe do for me? And the second page, so you want to try bupe. We wanted to keep the information mostly practical, reassuring patients that, you know, buprenorphine can be picked up at pharmacies, insurance plans cover most formulations, actually all formulations. Sometimes if you've got Medicaid in the mix, you'll need to do PAs. And we got a lot of feedback that the line, buprenorphine helps give you back control over your opioid use, that line was really meaningful. On the back page, patients gave us feedback. Originally, we put all of this kind of like flow chart into a chart, like comparing the 3 different ways that buprenorphine can be started, but people were like, you lost me in the charts. I don't like the charts. It needs to be simpler. And just to go into buprenorphine initiation for just a second, usually or historically, I should say, it's all about how much withdrawal people can tolerate. But since we have this new injection as a way to start buprenorphine, we decided, well, what if we start out by asking people if they'd be open to an injection? If so, it's a really simple choice. Just, okay, great, we'll do the injection. And if not, then we can go into more detail about people's withdrawal experience. And patients liked that. So we had distributed these flyers. About 6 months later, we decided to recruit patients to give us some feedback. We looked for folks to give us feedback from a Department of Public Health building that houses the buprenorphine clinic where I work, a mental health specialty pharmacy, and a team that provides patient navigation and telehealth prescribing of buprenorphine. We offered $25 Visa gift cards to 10 people. We now have about 20 people who have given us feedback, but I've just incorporated the first 10 who agreed to review this handout and give us their thoughts. We asked questions about sort of overall take on the handouts, if there was anything that was hard to understand or didn't make sense, if they would want to pick up the handout if they were in a waiting room, and if anything felt stigmatizing at all. So the buprenorphine handout people really loved. And I think a lot of the people had experience with buprenorphine who were in the specific setting where we did the first 10 patient feedback sessions. So people thought everything that they needed to know was on the flyer. If they hadn't known about the injection already, that they'd want to bring that up with their provider, and that it would make them want to ask their doctor, what's so special about buprenorphine? I had one person ask me, like, what's up with Narcan and buprenorphine? And so even just doing a patient feedback session, patients had questions that they wanted to engage with a healthcare provider about, which I thought was really, it's fun. It's what I love to do with patients. Next slide, thank you. This handout titled Your Health focuses on the idea that just like with any chronic medical condition, even if people don't ever change their lifestyle, like if someone has diabetes but wants to continue eating donuts the rest of their life, or if somebody has a substance use disorder and wants to continue using drugs, public health interventions and treating other comorbid conditions can significantly prolong life expectancy and quality of life. So we want our community members who use drugs to be empowered to know that they should ask about vaccines. They should ask about HIV and STI prevention, getting screened for blood pressure, cholesterol, have all the resources at their disposal for food, dental care, and other services. During my time as a primary care provider, it was always challenging to care for people who use drugs because there were so many preventative health interventions that I wanted to get to, but often people came in with a lot of other priorities. So either I was forgetting the preventative interventions, or if I was sort of putting my agenda first, then I was forgetting to engage people around their substance use. So this is meant to be like a patient tool, provider tool to make sure that things don't get missed. Next slide. Feedback from patients wasn't too interesting on this flyer. I don't know exactly why. I think they were more engaged by the information on the other flyers. They sort of said, oh, I already know this. And yes, this is great information to better your health, which seems like it sort of accomplishes its purpose, but I wish we had a little bit more constructive feedback on this handout. Our stimulant flyer, the last one to flash up here. So similar to the buprenorphine handout, we structured this one around questions to help patients contemplate the benefits of using stimulants and how they can protect their health if they use stimulants. A lot of people don't know that there are actually very effective treatments for stimulant use disorder out there, both behavioral and medication-based approaches. So this handout is really grounded in motivational interviewing, starting with the idea that if people can at least understand or start to understand why they use stimulants, they can assess with the right information to guide them if there's any reason that they would want to make any changes to their use. So it's meant to flow from asking provocative questions about stimulant use into a section on the back on how people can reduce their stimulant use with the help of contingency management and medications. And next slide. Here are a few of the sound bites from the stimulant use flyer feedback, which to me was the most fascinating. So I'll go through these. Someone said, yeah, this would be helpful for someone who doesn't already know the harms of stimulant use. If I wanted to get off stimulants, it would be helpful. Yay. Yes, that's what we're going for. Someone else had a moment of reflection. They said, I have these twitches that are uncontrollable. I thought it was fentanyl, but then read in the brochure that stimulants can cause Parkinson's. So again, that was another opportunity to engage with that person and say, here's what you can do. Here's how you can go to your healthcare provider and bring up this concern. And here's what to say if they say it's probably just your substance use. Here's the things to advocate for and really demand in how you're being treated. Another person said, I didn't know using stimulants while having sex could make you more at risk of contracting. Oh, and somehow HIV got cut off there. And that the flyer could say something like, speak to your physician to learn more. There was also someone who said that they would rather see something on the stimulant flyer like, what do stimulants do for me? They wanted to see all the harms listed up there and the health effects, and that they thought that the flyer should bring up the negative effects. We had, as a team, sort of decided we're not going to do that because we don't want to just make people feel bad or scared through this flyer. We really wanted it to inspire engagement with the healthcare provider, but that's another angle. Maybe if people see a list of the health effects, maybe for some individuals that would be more inspiring to go back and engage. So we're still thinking about that one. Many patients, I'll go back just for one more second. Many patients also said they wished they had known about contingency management before and that it could have been really helpful for them along with trying medications. Okay, now next slide. So overall, people really liked these handouts. There were really differing ideas about size. Some people liked the idea of making these into bigger poster-sized flyers at different clinics. Others wanted pocket size for each and every one for portability. Everyone was a fan of the colors, thanks to a patient who told us early on before we launched the materials that we should like think Folsom Street Fair, which I don't know how many of you know San Francisco and the Folsom Street Fair. It's sort of like a leather kink LGBTQ festival that happens every year. They were like, yeah, the flyers need to look like Folsom Street Fair flyers in order for people to want to look at them. People said they'd pick up the handouts to kill time, but that people on the street wouldn't be interested in them necessarily, which sort of confirmed that we were on the right track in how we wanted these materials to be used, either as something that patients could pick up in a clinic or that clinicians could use to engage patients. What we didn't get to in our feedback cycle yet is feedback from the clinicians who are using these materials. But if requests for more patient education flyers tells a story, then the demand for the handouts is definitely a sign that they're being used and desired by healthcare workers in San Francisco. We even have a group of shelter health and permanent supportive housing workers that have said, we want to get these handouts into all of the permanent supportive housing sites here in San Francisco because we're often engaging with people post overdose and we're coming in trying to start conversations, and having a tool would be really helpful. So overall, we've had a really positive experience expanding our academic detailing toolkit to include patient-facing materials in this way, sort of trying to utilize the direct-to-consumer approach, direct-to-patient approach. And we're hopeful that these handouts will continue to have an impact on our community to improve both healthcare worker and patient experiences when accessing substance use-related care. We've even gotten a request now for a methadone handout, and so we're about to launch that handout in the next month. I have no idea where I'm at on time, but
You are actually right on the money.
Oh, good. Okay, perfect. So yeah, I'd love to hear any questions or ideas. Yeah, thanks for everybody's time and listening in.
Thank you so much, Rebecca. We already have a question from Sally McNagny from Alosa. Any sense if the materials increased BUP use? That would be hard to measure, I would imagine.
It's so hard to measure. So I work with a team that does a lot of the epidemiology for the Department of Public Health, and it's so hard to make connections. And I don't think we've expanded enough that we'd really be able to track yet. We've focused our efforts mainly on academic, um, academic clinics, like university clinics and public health department. So we're like still missing a big chunk of the prescribers. But yeah, prescription tracking. Yes, I know the person who heads, so I work with Philip Coffin. Maybe some of you know Philip Coffin. But he's had this question for a long time. Even it hasn't seemed possible to even track like how our detailing efforts are impacting buprenorphine prescribing. There's too many sort of confounders with the politics of what's going on with buprenorphine prescribing in the city. There's just a lot of variables. So at this point, we haven't figured out, but if you have any ideas, please share. I'm happy to share my information. Those are some
Thanks.
outcomes that we'd love to be able to put out there.
I know it would be so interesting to like, if there was a QR code on the flyer and they accessed that code, it would sort of show a hit that might then, I mean, that's the only thing I can think, but that would only capture the people who were accessing information via their phone, and you would have to build in a survey component. That's where did you hear about this? So one idea, just some feedback here too from Christine Fishman of Metro Health in Ohio. I love the concept of these infographics so much. It's great to make an impact on the greater population and not just providers. Thanks, Chris. And Steve Hymans from Illinois says, have these patient-facing materials given better access to prescribers? Like, does a prescriber ever say, sure, I'll talk to you if you give me some patient resources? So is that incentivizing for having a one-to-one visit get set up?
I would say not ahead of time necessarily, but definitely it people's faces light up when we say we have patient-facing materials that we can share with you along with our sort of provider toolkit. We have a big provider guide that we use. So I think it builds rapport and it establishes a more longitudinal relationship when we're able to provide patient-facing materials. Yes.
Cool. Yeah, I think that's wonderful too, to say we have these materials and they've been tested. I mean, just like these are effective. We have one last one we can squeeze in from Talisha. Just curious, did the patients review all the handouts at the same time? Or was it, okay, we're going to focus on this one, we're going to focus on stimulants, we're going to focus on BUP?
We pushed out all three at the same time. So in the preliminary feedback sessions, yes, they were looking at all three. And then during our paid feedback sessions, yes, they were looking at all three, which I think a focus group could give more time to tease out the differences between them and get some more constructive feedback, like from that general health handout. So, yeah.
Pros and cons to going about it, right? If you do 3 in 1, then you're getting more info. If you do them separately, they're not comparing them to each other. So always interesting. But thank you so much, Rebecca. That was such a fantastic presentation. Really grateful for you being here. All right. We have another chat waterfall before our third field presentation, after which we will take a break. So how do you know when you are stressed out or at capacity? What are some signs? So what's the first thing that starts happening when you know you're stressed? I know for me, I am extra irritated when my cat meows because he never stops meowing. Vishal, apathy. Vishal, when you're apathetic, I know you're distressed. Debbie gets irritable. Jamie's right shoulder blade pinches. Mike can't focus. More for irritability. Silvana gets forgetful. Rocco goes into panic mode. We've got avoidance, indigestion, exhaustion, eyes twitching, not being as patient. Performance goes down. Can't sleep. Can't think straight. Foggy. Don't want to talk to colleagues who stop by while, to chat. More for trouble sleeping, snapping at people, stress eating, nausea, and irritability. Oh boy, we know our stressors really well. Not our stressors, our stress responses. And then, of course, we have decreased appetite as well. So all the main functions start to, the switchboard starts to go awry. And Gustavo from Brazil says, need to be alone. Right there with you, Gustavo. All right. Well, up next, we have the fantastic Amy McWeeny, who is going to be talking about detailing within your capacity. She's going to be sharing stories and talking about the importance of storytelling. And I'd love to turn it to Mike to give a formal introduction to Amy.
Fantastic. Yeah, I'm going to be mentioning this in our intros. One of the many things I love about our community is how geographically representative we are. So we've gone from Saskatchewan to San Francisco, and now we're just a little bit north of NaRCAD headquarters here in Boston, up in New Hampshire, the New Hampshire Department of Health and Human Services, which is where Amy McWeeny is based. She's a public health detailing specialist there. Working across New Hampshire, educating clinicians on infectious diseases. There are small programs where she does research, she meets with subject matter experts, she creates materials. Amy's background actually is originally as a physical therapist, so that's another one of those sort of circles we talked about in the opening today of the diversity of professional backgrounds and disciplines that we all come from. She's worked in a wide variety of environments that inform her AD work. As Bevan said, she's going to be presenting on detailing within your capacity, mastering virtual storytelling and conversational engagement with providers. Amy, take it away.
Thank you, Mike. So that was a lovely introduction. You basically gave away my first couple minutes, but yeah, go ahead, Bevan. Go to the next slide. So the agenda for today, and then I'll introduce myself, but I want to discuss how to be authentically you, because I think that being authentic to yourself is so integral to your success and your stress level, which thank you for all sharing about how you feel when you're stressed. I want to talk a little bit about a story that I used recently in detailing for hepatitis C. I love stories in general, so I like to use them in detailing. And if time permits, we'll present some engagement tips that helped me to be successful when communicating with providers virtually, and a little reflection on learning. But as Mike said, I do work for what's lovingly called FED, the Public Health Education and Detailing Program with the Bureau of Infectious Disease Control for Public Health in the state of New Hampshire. Okay, and the last thing I want to say, you can keep it right here, Bevan, that's fine, is I also set an intention. So I know that's our agenda, but whenever I meet with people, and I know this is a little hippie for some people, but I like to set an intention of how I want things to go. And so my intention, which typically is very common for me, is to send a lot of light and love to all of you out there for the amazing work that you're doing. So nothing to disclose for conflicts of interest. So I want to give you a little background. This is a very different conversation than me sharing with you my hepatitis C or HIV prevention kit, because I really was reflecting with Bevan on why I love my job. And why am I not stressed when I'm one person doing the entire state of New Hampshire? It's insane, right? So who I am and how did I get here? So again, like Mike said, I'm a PT. I've had an amazing career as a physical therapist, did brain trauma and stroke rehab. I became a director of rehabilitation, and I managed PTs and OTs and speech therapists. And then, I wanted to teach. So I became a professor and a department chair. And I thought, this is fabulous. But then the college closed. So what did I do next? I always wanted to be in hospice. So I went back and managed home care and hospice. And then I thought, I'm getting old. and I still want to treat patients. And this is probably my only opportunity to do that. So I went back to treatment, and I loved all of it. It was lovely. But then I had some health issues and COVID happened, and I thought, now what am I going to do? I really can't keep up with that. Again, reflecting on my capacity, I guess I've always been this person to do that. And I found a job in public health initially for the Ryan White Care Program. And then a job came up in public health detailing, and I thought, what is that? I only know about detailing a car. I have no idea what detailing really means. And I realized it checked a lot of boxes for me, for pleasure, for some of the skills that I had. And when I first started detailing, I felt like a fraud. And I'm saying this because I really want to share with full vulnerability. I was like, I'm a PT, I'm a professor, I'm a mom, I'm a wife. How am I a detailer? Right? And what clicked for me finally was that who are we as detailers? What are we doing? All we're doing is communicating with another human being and sharing some education and working collaboratively to do good. And I thought, oh my gosh, I've been doing this my whole life. So then it became really like, who am I as a communicator? How do I be myself? So I think a lot of times we wear this mask, right? Like people say, how are you? You're like, oh, I'm good, right? I'm totally fine. So we wear a mask a lot, but like take the mask down and be vulnerable and be yourself. What does that look like for you? Because for me, that's made amazing connections with people. And I love my job because of that. So, reflecting when I was like, okay, I'm one person, how do I do all this stuff? I thought, well, for me, I still had a health issue. So I didn't want to be going into a lot of doctor's offices. New Hampshire's a big state. We have a big rural area, especially in the northern part. How do I get to all those people? And so virtual detailing just started to be like, okay, I need to become a virtual detailer and I'll feel better about that. And so I think reflecting on who you are and what your capacity is so important. Now, how do I reach all those people, if I'm one person? And this morning, I actually looked at my data. We have a database that we use, like a Salesforce. How many facilities on my own did I touch and educate and get my kid out to for hepatitis C? And it was 659 facilities. But how did I do that? And Mike, this goes exactly with what you were talking about before. I created really strong relationships with leaders in the healthcare teams that will bring the information throughout to the providers. So I'll meet with all the infection preventionists of the hospitals in New Hampshire, and they will trickle down the information to all of their providers in the hospital setting. Oftentimes I'll meet with a chief medical officer of, let's say, a large urgent care, and that person will do the same. And then I'll do some touch points to make sure that that information got to those local groups. But that's been huge for me to be able to really touch a lot of people. Now, if I think of 659 facilities, then I think of how many providers we got that kid out to, which is amazing, really amazing. So a chat waterfall question, and if you could type in the chat, go ahead and hit there. What does authenticity mean to you?
All right, here we go. Amy, you want to read some of these or you want me to do it?
Go for it, Bevan.
All right, being genuine, not faking it, bringing your whole self to the table, being you, flaws and all, feeling like I belong in my own skin. Love that, Mary Jane. Being real, feeling like my true self, being present, being relatable, being genuine, being present with every detailing session in person, being honest and open, being youer than you, the truth and being honest despite possible negatives, a combination of honesty and vulnerability, my core personality, believing in your message, connection, embracing your strengths as well as your flaws, being willing to sometimes appropriately share aspects of my life that are relevant. What you see and hear now is what you would see and hear anytime, whether I'm being watched or unwatched, and being fearless of removing the mask. Love a lot of these, and I can tell you do too, Amy.
Yeah, I do love it because it makes that connection that you are all having with people so real and so much more powerful. I love it. Thank you for sharing all that.
All right, up next, more from
So,
you.
yeah, so when I was looking at what authenticity meant, I found a few things, right? Because I knew what it meant to me and I love what it means to you. But here's an example. Authenticity is the daily practice of letting go of who we think we're supposed to be and embracing who we are, by Brene Brown. I like that one. Mike, you spoke about hard times. So hard times arouse an instinctive desire for authenticity, Coco Chanel. So what a great time to be authentic. And then the privilege of a lifetime is to become who you truly are by Carl Jung. I loved all these, so I wanted to share that with you.
All
So
right.
really, this is a good conversation, right? This is really, I hope this is as conversational as it can be when we're working virtually like this. But I'm learning from you as you're learning from me too. But what's one thing you always do in a detailing session to ensure that you're being authentic? So now we've moved from your authenticity in general, but to detailing. What are you doing during a session to be authentic?
And if you're not detailing yet, you're not a detailer, you're a program manager, what would you do? All right, we've got inviting laughter, acknowledging something local about where the provider is located. That's important to make the provider feel seen for where and who they are and where their local culture is. Vishal loves small talk, talking sports. We know that. Trying to find something to connect with outside of the professional realm. What are other ways that folks who are detailing or meet with clinicians maintain their authenticity? Let's throw a couple more out there and then we'll go back in. Rebecca says, sharing from my own experiences and challenges, making sure it's a two-way conversation. Yeah, gotta be a dialogue. Inviting someone else's authenticity in, thanking them for their time, building rapport, attuning to something personal that's been shared so you can show that you've heard and reference again, more on creating rapport, including something that resonates with full disclosure. And let's do a few more. Talk how you normally talk, not trying to put on airs of using fancier language or different language, not rushing, and sharing doubts and areas of uncertainty. That's certainly a very real way to be authentic. Back to you, Amy, and keep them coming if you have more thoughts.
I love these. Thank you so much. So one of the ways too that I've tried to bring some authenticity and the human connection in is with storytelling, which I think we've talked about many times before at NaRCAD. And so I want to give you an example of that. And the way that I got this story, I'll give you a little bit about that in a second. But let's talk about the power of storytelling because I wanted to remind us about it. But I love it because it inspires the human side. And when we tell a story, we get emotional, we feel empathy, we can relate and understand the world and ourselves better. Increases engagement. That's one of our main goals that we're trying to do when we're speaking to people. We want to hear from them. And sometimes when we do that meaning and shared experience together, we can do that. And fostering connection and building relationships for me, that's my favorite. Always has been, probably always will be. And it improves learning outcomes. So we want to be asking for things. We want to make sure people are really learning from us. Before I tell the story, I do want to say there is a little bit of a warning here about sexual assault. And I just want to tell a couple things before I tell the story. This story was given to me from a case manager at an AIDS service organization about one of her clients. There's no patient information in it, but two things to know about it. So this was in my hepatitis C detail, and one of my asks was for healthcare providers to not make sobriety a restriction to getting treatment. That even though people are using drugs or drinking alcohol, they should still be getting treatment for hepatitis C. And that ultimately, if people don't get treatment, they can die, often of liver cancer. So I'll give you that background a little bit. But this is her story that she has given me permission to use throughout my detailing. Client died in 2015 of liver cancer at age 46. He had a lifetime of trauma and difficulties. He suffered severe abuse at the hands of his parents. He lived in constant shame as a gay man. He suffered from alcohol abuse and had severe anxiety. He was warm and very generous with what little that he had. He had a wonderful sense of humor and was capable of great kindness. He had a hepatitis C and HIV diagnosis. The hepatitis C was monitored, but never treated. The provider stated this was due to his continued alcohol use and his sometimes spotty adherence to his HIV meds. The provider would say things like, "Show me when you're ready," meaning he must change his behavior before being offered treatment. He was devastated by his cancer diagnosis and tried so hard to fight. He passed within 6 months of his cancer diagnosis. And this is why we do the work that we do. It's such important work. And if you could take a second and type in the chat, how did the story make you feel? With a few adjectives. Yeah, angry.
Yeah, sorry, that's me.
No,
All
I
caps
know.
angry.
I see the caps. Yeah.
There's my authentic anger. What else, folks? Heartbroken, we have from Vishal, reliving similar stories. Sorry, Dave. Upset, reflective, saddened, more for upset and sad. Indignant at my fellow physicians, not the first time. That's from Elizabeth up in Maine. A few more for sad. Yeah, this is a tough one. Sick, really sad, says Gustavo. Motivated to do better for patients. Yeah. Yep. We'll get a
My
few
goal,
more in
right?
there.
Yeah.
Keep
Yeah.
them coming, but we'll move on forward into the Hep C detailing kit. That is such a beautiful action kit that Amy's been a part of developing. And one more from Trish, seeing the patient as a whole person and not just as their substance use. That is so critical. Back to you, Amy.
Yeah. It is. And it's like sometimes you just want to shake people and make sure we remember we're all busy working, but we're working and we're humans and the patients are humans and the providers are humans. So getting that human moment is so important. And you know what, Bevan, I'm looking at the time and I know we only have 5 minutes. But we'll go right through that. I'm happy to share this kit. It's been so successful, but here's some of the quick things that have made this virtual detailing successful for me. And we can go through this because I really want to end with a little bit of a story. So I think we can
what
go
I'll
ahead.
do, Amy
Yeah.
and company, is I will share a link to this kit right on the NaRCAD conference website so people can peruse it on their own time. But it looks like you've got, tips and tools for virtual detailing. Do you want to talk through this one at all?
Yeah, I'll give a quick thing, but it goes with the same thing about being authentic. So how to be a good person, opening the room early and being yourself and really actively listening to what people are saying and letting people know how the meeting is going to be, hey, I'm the kind of person that really loves conversation. So please feel free to interrupt me. This is super casual, setting the tone for who you are and what you expect, being cognizant of time, but saying, like, I'll be cognizant of your scheduled time, but I'm happy to stay longer, ending with, what else can I do for you? How you can reach me? Let's put something in the calendar to see each other again. So just that very natural human side to things, to keep things human-sided. So I started with a story, and I know we have a few minutes, but I want to tell you a great story. So this kind of goes back to what Mike was saying as well. Mike, you must have like just hit it up for me. You teed it up. So why do I love my job? What did I find out from this detailing? So I get some contact from an epidemiologist that we work with, and she takes the reportables for hepatitis C. And she said to me, "Hey, Amy, I don't know if this is in your thing or you want to do this, but I looked at a reporting form that said, did not treat, will look at the person in 6 months and see if we need to treat then if it doesn't resolve on its own." And she said, "I can't think of a clinical reason why this would make sense. Do you feel like you want to dig into this?" And I said, "Heck yeah, I want to dig into this." So this is with a very large gastroenterology group in our state, mind you. So I had to go in softly, collaboratively, not punitively, friendly, and get trust out of this group. So I started with a detail on general hepatitis C and did some follow-up. Long story short is this particular provider didn't understand the insurance for treating hepatitis C acutely, and therefore didn't think that she could. And that's another long story, but I reached out to our pharmacy director at the state and got all of the minutia explaining why she didn't even need to do the billing the way she was, and educated and got over this barrier together collaboratively in a friendly way. Long story short, we were able to pull back all the people she turned away from acute treatment in this group and treat thousands of people for acute hepatitis C. And then moving forward, nobody will be turned away because of just, lack of information about billing. By keeping it friendly and supportive and collaborative, I still meet with this group on different topics. So for me, the reward of knowing how many people we touched to get them the care that they deserved was immense. So I learned that specialists need detailing too. So all the gastro and ID groups, infectious disease groups in New Hampshire are getting hepatitis C detailing now. And working collaboratively with our epidemiologists has been amazing. And the job satisfaction from that reward for me just makes me want to keep doing my one-woman show and just keep at it, because I really love what I'm doing. So I thank you all so much. I know we have like a minute for any questions, but I'm always available. So if you need anything, email me. And I wanted to leave with a really nice thought. What you do makes a difference, and you have to decide what kind of difference you want to make. By Jane Goodall. May she rest in peace.
Rest in peace,
Yeah.
Jane.
Yeah.
Well, we do have
thank
just
you.
a moment for questions. Thank you so much, Amy, and great quote and lots to think about here. It seems like this, maybe this is my disservice to you, that this could have been a breakout session where folks could talk more about this, because we know, as especially does the DISH group and the Iowa group, how impactful. You've got evidence, but storytelling goes hand in hand, right? Those two things together can really pack a powerful punch. And so if you do have questions or more thoughts about storytelling for Amy, please let us know. We can certainly triage those to her via email. And I think some of the important ways to wrap up this morning session, or actually it's the afternoon, except maybe in San Francisco, is to look at the ways that whole person approaches are really critical, whether you're looking at clinicians, whether you're looking at patients, and whether you're looking at yourself. So I really think that wrapping up here, really kind of taking a moment to think about how authentic you can be in any of your work in this sphere, and not changing tone or putting on a different hat or a mask. That gives us a lot to think about, Amy. So thank you to all of our field presenters. I wish we had an extra moment here, but you are overdue for a break. Our next presentation, following the YES, Trauma Attuned Detailing for Thriving Clinical Teams. And this is what we're calling this year's Speaker Spotlight. So from now until 2 o'clock, you have the pleasure of connecting with Nadezhda. Please keep any questions flowing through the chat box, and we will triage them as they come. And over to you, Mike.
Fabulous. So welcome back, everybody. As Bevan said, we're really excited about this spotlight speaker part of the conference, and especially excited that we get to welcome Dr. Nadezhda Razi Robertson back. She's been a long time NaRCAD ally, partner, and all-around friend. Her background includes working on a range of collaborative projects. She's presented at our NaRCAD conference on prior occasions and in many other educational and academic venues. She's especially focused on supporting teams to address burnout with education and coaching, and especially thinking about trauma-impacted teams, so frontline medical staff, wildfire responders, really drawing on her deep clinical background. It's included topical work like providing coaching and support to those who are directly impacted by the events at the US Capitol, January 6th insurrection. As Bevan mentioned, she's the managing director of Synergy Health Consulting, but more important for us, she's really one of our treasured colleagues. So we're excited to learn from her about following the yes, trauma-informed detailing for thriving clinical teams. Nadezhda, over to you.
Thank you so much for the warm introduction, and it is so good to be back at this conference. I want to say that just this has been a space that I think has so informed me professionally. I was first sent to NaRCAD in 2016 to learn about what academic detailing was after having been asked to develop an academic detailing program in Southern Oregon. And I said, sure, but I had no idea what academic detailing was, and went to NaRCAD. And I think that really that just the opportunity to learn from all of you here in this space and at this conference. And I think about the experiences over time in this setting and how each time I have had the opportunity to be at this conference and learn from this kind of global community, how much it really informs and shapes and changes the work that we are doing. And so this is a really meaningful space for me. And specifically, the last time we were there in person, for me, that was 2 years ago, I believe. It was the time where I got really clear that we needed to pivot in terms of how we were talking about the work that we were doing. The work of Synergy Health Consulting is kind of this continuation of this work with the Oregon Pain Guidance Group. Some of you all here may be familiar with the Oregon Pain Guidance website. The founders of the OPG worked with me to begin Synergy Health Consulting. And since, I would say really 2010, we have been doing work related to overdose prevention and intervention around the state of Oregon. And it's taken many different forms over many years. In the COVID time, what started to become so clear to me was both in my clinical practice, where I found myself working almost solely with medical providers and people doing frontline healthcare work in treatment centers, et cetera, was that there was just so much burnout. So both in the one-on-one work that I was doing with people providing care, with leaders, and in the context of the organizations that we were working with, people were just kind of stretched in ways that I had never heard before. And it started to feel like a lot of my focus and the focus of our team was on kind of shoring up the workers. And I became kind of increasingly interested on how do we start to support people in being well in the work when the levels of acuity in the world are increasing and growing. So next slide. So we do all different types of work. The thing that I would say is a bit different in terms of how we do academic detailing is that when I think of a more traditional academic detailing program, it's often that the content that is going to be disseminated is already decided prior to engaging an organization. And the way that we have been doing this at Synergy, and it's kind of an adapted approach, has been we very rarely know before we go what it is that we will specifically be talking about. We have a broad range of consultants with expertise in lots of different arenas, in addiction medicine, in integrated behavioral health, in chronic pain treatment. And now a really amazing group of folks whose passion is really in addressing workforce wellness. And when we go into an organization or a community, or a team, or doing one-on-one work with a person. We don't necessarily, we really listen first to understand, okay, what is the content that is needed? And so in more recent times, we have really been also including this workforce wellness work. The title makes it seem like the focus is on kind of trauma-attuned detailing kind of out in the world. What's true is that we have been bringing the academic detailing approach to teams to support wellness in the context of teams. Next slide. So for those of you and those of us that have been doing work in the space of all things overdose prevention, treatment of chronic pain, opioid use disorder, etc., stigma is something that we've been talking about for quite some time. And I know NaRCAD has done such an amazing job at centering conversations around stigma and addressing stigma in this space and otherwise. We have found that while stigma is such a huge component and barrier to best practice, there are some other players that are also deeply impactful in this space. One is moral injury, and we'll be talking about that more. And the other, which is one that I don't hear talked about so much in the world, but that I've come to think of as really one of the prime culprits to both burnout and also a real barrier for people to be able to be available to hear new information, is the unconscious protective responses that can arise in doing this work. So stigma is a learned belief or bias, often social or cultural, that assigns shame and judgment to people or conditions. The wonderful news about stigma is that it can be addressed through education. And we, I think right now, are living in a time, if we think about how much the space around addressing, I think just all of the stigma around treating addiction, it's a very different landscape than it was 5 years ago, than it was 10 years ago. And we have learned that sharing evidence that contradicts stereotypes is really impactful. Highlighting personal stories to humanize people and to illustrate that our beliefs, that we shouldn't believe everything we think. Facilitating discussions that allow reflection on bias. All of these can be just hugely impactful in changing how we think about and treat substance use disorders and trauma and pain. When we have the opportunity here from people who are thriving doing this work, there are certain themes that we kind of hear over and over again. People who are feeling fulfilled and excited and engaged and well in the work of treating people with substance use disorders. They understand that recovery isn't linear. That return to care and treatment is a part of the process and not a failure. They understand that it's the role of care teams to meet people where they are and to continue to learn and kind of grow the toolbox so that we can be as adaptive as possible to really, find the entry point, to find the yes in the care. Relapse is information. It's part of the picture of what's happening for a patient. It's not personal. It's not a betrayal. They understand that connection and relationship is healing, that the relationship is medicine, that compassion and boundaries can exist simultaneously. They are people who tend to really understand the complexity of the system and how impactful that can be, the role that the system can play in addiction and addiction treatment, and that our worth as providers is not defined by patient outcomes, just that that the wellness in the work is really around showing up and doing the best that we can with integrity and care. What we're going to be focusing on today is that is when education is not enough, and when even the work of addressing stigma is not enough. And what we've come to understand, and the way I like to think about this, is that it's an inside job. When education doesn't move the needle, something more is being asked of us. And it means often that we need to be willing to look within. And it's the work of self-awareness. So one of the things that can come up so often in this space is moral injury. In its simplest form, I think of moral injury as what happens when we say yes, when we feel a no, when we are having to cross a line that feels misaligned with our own values, kind of inner conflict that can come from engaging in any type of activity when our instinct says, no, thank you. Moral injury and SUD treatment can look so many different ways. The themes that we hear the most are people experiencing a real lack of efficacy in the work. Lately, we've been working with a hospital in rural Oregon, and I've been hearing a lot of providers speak to how demoralizing it can be to see the same patients return to the ED or to the ICU and feeling like the kind of pointlessness of their work. What's the point in helping? What's the point in continuing to provide care? A lack of efficacy. We see the moral injury arise around ethics and values and conflicts there. I think this is particularly interesting in the context of teams and organizations when maybe two providers on one care team may have very different values around treating patients with chronic pain, for example. An organization we're working with right now, there's a situation where all of the providers who have remained on the staff after two providers gave their notice feel very strongly that they do not want to be prescribing any controlled medications. That is distinctly kind of out of alignment with organizational values, and we're seeing the ways that it's causing a lot of kind of internal tension and conflict. And of course, the world of very limited resources and restrictive policies, we can just all the situations where we can see that there might be needs for patients that we don't have, that people don't have access to. In the world, according to me, burnout's greatest culprit is the unconscious protective response that we see coming up so often in the work. So this is a protective response. It's automatic. It's not intentional, and it's aimed at reducing our own discomfort or perceived sense of threat. I'm hoping to come up with a good acronym for this, but other ways to describe this, right? A default safety mood, automatic guarding behavior, hidden coping, unconscious safety behavior, subconscious safety reaction, a reflexive safeguard. Here we see the turtle who's pulled his head back into his little shell there, just having a reaction to something, to a perceived threat. It's kind of this reflexive response when we are feeling uncomfortable or unsafe. And these unconscious protective responses can come up in so many different ways. So they can be physiological, they can be behavioral, they can be cognitive, they can be emotional, they can be relational, they can show up in how we communicate with each other. So rapid heartbeats, avoiding tense coworkers or difficult conversations, defensive responses, over-apologizing, taking things personally, anxiety, guilt, shame, irritability, Numbness is one that we hear so much. People really kind of shut down about the impact of the work. And in communication, just tension, interrupting, sarcasm, minimizing concerns. All of these are these reactions that we can have to protect ourselves. And they can be very helpful and necessary. And they can also get in the way of being able to take in new information and provide best practice care if unaddressed.
So let's press pause for a moment.
Yes.
And this is interesting because in your prior slide, Nadezhda, my mind is going to thinking about members of a care team, clinicians, and extended members of the team having some of these barriers get in the way of not only showing up for patients, but being able to receive new information from a detailer. Let's kind of apply it to ourselves here. This is a great question from Nadezhda. What are some of your automatic protective responses? So we did ask a little while ago in a different session, what are some signs that you're burnt out? This is not exactly the same, right? But it's sort of adjacent. So give an example, a lot of you wrote before, like irritability or apathy. Can you put together an example of something that may happen, those of you in the audience, that is a sign that you are going into your turtle shell, that you are having a reflexive response? So we'll give you a minute to think of that. I know for me, it's if I'm short with my partner and snappy in a way that is more than my usual snappiness. Mike throws in looking for someone or something to blame. Narissa says silence. Richard says losing the passion, that sort of apathy. Denise says sorrow, snapping at loved ones, wanting to go to sleep earlier than usual, shutting down. The fridge becomes my best friend. Yep, that makes me think of what you had on a prior slide, Nadezhda, about the coping responses. Very long solo walks. That seems like a healthy response. Less patient at home, overwhelm and burnout at work. Yeah, fatigue. Keep those coming. And, Nadezhda, if you want to share a few more examples that would fit into these categories, we'll move on to the next slide.
Thank you. Thank you for your responses. Yes, so over controlling or overworking, blaming patients or systems, avoiding difficult conversations, minimizing impact. All of these are the types of things that can come up in the work and are common examples of this.
And I was just throwing into being defensive when new information is shared, which is something that I know detailers might have to deal with when they're coming in with new evidence.
Absolutely. So, when we are in this, when we are having these types of responses, it really impacts our clinical judgment. And the truth is that we are, all of us are human. All of us are being impacted by our experiences. All of us we are relational beings. We are attuned to each other and each other's states. And so this is the type of thing that I think often going into this work, and when we think about what does it mean to be professional, many of us are taught like, oh, we've got to leave the emotions at home, or we can't show that we're being impacted. I think that in COVID times, with things starting to happen more virtually, and also again with this kind of growing acuity in the state of the world, it's become kind of harder and harder to maybe even kind of code switch or hold that line or know what the line is between the personal and the professional. And we are working oftentimes in these spaces with patients who are very dysregulated. And it can be very common that we in turn become dysregulated in doing the work. And we are also affected by our coworkers. So there's a way that we have, it's not uncommon for there to be kind of a culture of a workplace is a culture of dysregulation, which can look like overperforming, high levels of stress, a lot of reactivity, and where people, in order to protect themselves, really need to be kind of shut down or in overdrive. And often this is happening outside of our awareness in the context of the workplace. And this can really impact our clinical judgment. One of the themes that we've heard quite a bit recently is specifically in this hospital that we've been doing some work is, I'm tired of helping patients who do not want to be helped. I wanted to feature this particular sentiment because I think it can help to illustrate the relationship between stigma, moral injury, and this unconscious protective response. So this belief, this stigmatized belief that people who relapse on drugs and do not seek treatment do not want to be helped, right? In this particular setting with the people that we've been speaking with, that belief is really causing this sense of moral injury. People are feeling really injured by the experience that their treatment and care, that there's no point in it. They are feeling burned out from feeling like we're helping people that don't want to be helped, which in turn is bringing up this unconscious protective response. We have different parts that can show up. So just briefly on this, right? Some of us might tend towards being a fixer or a performer or a critic. We might shut down, we might defend, as you all shared in the chat waterfall. A thing to keep in mind with this is when a reaction feels bigger than the moment, an old part of us is likely involved. An old part of us might be reacting based on previous experiences, something that might have happened in a past job or childhood, or moments where we felt powerless, disrespected, or not good enough. So I'm going to share a few examples from the field that I think illustrate well where education is not enough. One is with a provider who had received quite a bit of information and was actually very bought in to upon learning that the way that he was prescribing opioid medications was unsafe, not ideal, and that there was some improvement needed in lowering the doses and kind of reconceptualizing how he was treating patients with chronic pain and on long-term opioids. One of my roles was to spend some time with him and to help him in having difficult conversations with his patients about how he would be doing some tapering of patients and would still be their provider, but there were going to be changes in their medical care. And what became evident after a number of hours and a series of patient visits is that he was able to have that conversation very effectively multiple times in a row. But when it came to patients that were female patients who became tearful, he was unable to kind of uphold his boundary or follow through with his plan to begin the process of changing the way that he was going to be prescribing. And when we had an opportunity to talk outside of the patient room, and I asked him, I shared the observation, just that I noticed that it was hard for him to kind of stay the course in the face of women who became tearful. He kind of stopped in his tracks and said, gosh, I've never thought about this before, but this reminds me so much of, and then proceeded to tell a story about how his father had left home when he was 6 years old. And he was an only child and became so kind of committed to helping his mom and felt so deeply uncomfortable with her tearfulness. And when he had the insight that what was coming up for him was actually unresolved wounding around the dynamic with his mom. It was so impactful for him, and he was able to change how he was prescribing and have those conversations with his patients. And it really shifted his ability to, he was able to see that what was happening for him was this kind of unconscious protective response that was a carryover from his past. I think before moving forward here, I want to call out that in a few other examples that I think can be really helpful. When we see teams and work with teams that are taking time to have conversations about what is, and kind of normalizing the reality that a lot is coming up in the context of the workplace. And when that is prioritized in teams, it's dramatically decreasing the experience of burnout. And in teams where that is not being addressed as much, there's a lot of, we're just seeing so much more struggle internally. Another piece that I think is important to name is that in organizations where this is being addressed, many times there are, team members will describe a very activated or threatening incident with a patient, and they are, they report feeling afraid or feeling kind of not knowing how to handle the situation, and the event in and of itself is quite disturbing. When leaders and organizations address the situation with staff, it can be so impactful on minimizing burnout and overwhelm. When the incident is not addressed, we see that it can really compound some of this experience of burnout. So some of the topics that we have been bringing to teams to address these unconscious protective responses, and bringing them in an AD type of approach. So sometimes it's a one-on-one session. Sometimes it's mini virtual kind of 15 to 30-minute educational sessions. Sometimes it's in the form of longer trainings, but we've been bringing information about what is self-awareness. What is it? Why does it matter? And how do we start to cultivate more awareness about what's going on for us? We talk about our emotions as tools, not as something that is kind of unprofessional. We look at basic needs, identifying activation, why it's happening. We talk a lot about self-regulation and co-regulation, boundaries, moral injury, and really, like, why are difficult conversations difficult? We also do trainings around how to have difficult conversations, but kind of really kind of more upstream, focusing on what is coming up for people in the work and normalizing that this is happening. And actually, unless some of this is addressed and talked about in the context of work culture, it's really hard to start moving the needle in terms of how we are providing care. Here we are really just getting into how we do the work with organizations, which I think really mirrors a lot of what we do and all of us here as detailers do. So we start with listening sessions. We're really trying to understand what the barriers are to providing care. So we start by listening, and then we tailor our responses to based on what we're hearing. And this can come in, again, many different forms. We do one-on-one sessions. We do 15 to 30-minute educational outreach sessions. We provide longer multi-hour interactive workshops and trainings. We've been doing some short video-based wellness mini sessions. So having content experts information and recorded sessions that are shared in existing meetings. I would say an example of how we are kind of bringing this type of content alongside more clinical content. With a couple of the clinics and hospitals that we're working with, we'll be doing trainings on answering specific questions about medications for treating substance use disorders, while also, when needed, bringing this type of content. So I'd like to pause and just kind of open it up for questions here. I'm curious how any of this is landing, and then, yes, as detailers, if you are kind of picking up on any of this in the work that you're doing in the world.
It looks like we have a question coming, and we did have a reflection that said, I'm imagining a world in which more therapists do academic detailing. I'm sure there are plenty of questions about how to apply some of this, Nadezhda, but right now we have one from Amy that says, how do you encourage, I'm sure, clinicians you meet with to speak openly and honestly without fear of repercussion, either from other team members or management? Yeah.
Thank you for that question. And I think that it is so hugely important to get leadership buy-in. And so it's much harder to do this in context where leaders are not bought in. And it is just makes such a difference when leaders and managers are on board for supporting this work. And we've found that it is most effective when leaders are involved. Either participating in meetings and conversations and trainings where they are willing to have transparency around what's happening for them in the work as well. And so organizations that we've seen kind of do multi-years of doing this work and bringing this work to their leaders and managers and supervisors, it's so powerful to see what can happen when there is a modeling happening around we're human in the work and we're being impacted by our own lives and by the experience of the work. So I think leadership buy-in is really essential. I think what I have found is that certainly there's this kind of added layer of being a therapist in the work. I think that actually being able to just share information, even really simple information like about, let's say, the concept of the window of tolerance and what does it mean to be dysregulated? What does it mean to be activated? And how does that impact our ability to take in information? Some of these pieces of information can be pretty simply communicated and really go a long way. I've had non-clinical people, non-therapist people share that information, and I'm hearing people have the handouts up on their computer with little kind of exercises and reminders that that people are kind of drawing on.
There's a question here from Sally, and then I know a question from our team. So Sally McNagney from Alosa asks, when your clients engage your consulting company to come and talk with clinicians, do they pay clinicians to speak with you? I'm curious, since most practicing clinicians have very little time outside of seeing patients. Yeah, how do you build those relationships where you're coming in and kind of using the AD approach to ascertain the sort of workplace culture?
Mm-hmm. It happens in different ways in different organizations. Some organizations it is part of the paid time. And we are always trying to adapt, similar to just, we're always trying to find the entry point into what will work for the providers. So it's quite common that we might do a presentation in the context of an existing provider meeting, for example. For CME trainings, that when people are kind of getting CME for the work. So as much as possible, it is happening within the context and built into the context of an existing workday where providers are getting paid to show up.
That makes a lot of sense versus an additional ask.
Mm-hmm.
Nadezhda, our team has a thought and just kind of a question of, this is so much good information. Since most detailers are not therapists,
Mhm.
Is there one thing from the work that you've done and the discoveries you've made and the approaches that you take at Synergy that any detailer could use to apply when they're walking into a space where a clinician with whom they're meeting may have a protective barrier up, may be dealing with a lack of wellness in their culture that could help that detailer move the needle a little bit, or help that detailer help a clinician be a little more receptive? Like if you could kind of break it down for like the non-therapist crew on the call, what could they do that's maybe something simple and doesn't require them having an LICSW?
Yes, I think that similar to when we're thinking about approaching a patient that is experiencing a lot of activation, um, the importance of validating before we can educate. I think about this communication model that I believe came out of the VA, the VIMA model: validate, educate, motivate, activate. And really just this understanding that we cannot receive education and information until we are validated in our experience. So oftentimes, and I think that there's a parallel process here. So I think when we can see as detailers that it is challenging to take in the information at hand, or the information that we're trying to deliver, it's important to consider, is stigma playing a role here? Is there information that can be helpful, that can help to address the stigma that is present? And also, might there be something else going on here? And if so, really creating the opportunity for the person to speak to, what is coming up for them. I think a lot of this exists already in the AD model, where we are kind of validating and identifying the barriers and kind of preemptively understanding what might be coming up as a barrier in receiving information. But my sense is that it can be sometimes we tend to skip over the validation into the education, and it can be helpful to realize that there can be more going on than just the need for addressing stigma.
So what I'm hearing you say is that if clinicians themselves felt more validated, and if they also had a tool to help them validate their own patients' experiences, that alone might be something that would kind of help communication both between detailer and clinician, and between clinician and patient. Am I oversimplifying that, or does that seem?
I think that's exactly right. Validating the provider.
Yeah.
And
Yeah.
validating the provider, and absolutely.
Yeah, and I think that goes to that combination again of empathy and evidence, right? There's only so much evidence we can bring to people, but if they don't feel seen in their struggles and the unique climates in which they work, and especially given the climate that we all know is happening in the US, providing education might fall on deaf ears. So thank you for that. And I actually found your VIMA communication model right there on OregonPainGuidance.org. So it's in the chat box, and you'll all receive it via email after the conference. We have another question here for you, Nadezhda. What do you think of motivational interviewing as a tool? There's a lot of trainings out there that are available. Do you have any kind of pros and cons to that approach being something that's interwoven into detailing?
I think it's a wonderful tool, and I think I don't have any cons that come to mind. I think motivational interviewing is such a helpful tool.
Excellent, excellent, excellent. We can include some materials about that as well. Nadezhda, do we have time for maybe one more question? And I know you want to also share a little bit about adapting some of your approaches to specific environments. What direction would you like to go in?
I'll take another question.
All right. Anybody else have a question about application for some of this? Feel free to type it in the chat, or you can unmute. All right, well, we'll pause and wait for someone to pop it in the chat. make sure you have time to cover these last pieces. If I could, Nadezhda, I think this piece is really, really key here with the few moments we have left, and these response skills really as well. So are you comfortable with us kind of sliding right
Absolutely.
into that? All right.
So yes, in terms of sharing the AD framework, um, the parallels that we see are, you know, with sharing the evidence, this kind of normalizing the stress response, and bringing information that helps people understand kind of why this work is so hard. I think that there's something that I heard over and over and over again, and increasingly during that COVID time, of just people feeling like, why now? I've been doing this for 20 years. Why is this getting so much harder for me? What is going on? Why am I now? I've never thought about leaving my career before, but now, you know, now I am thinking about leaving my career. And it was so helpful for people to just even hear the information that normalizing the stress response, it is normal that you're having this experience, and not just normalizing, but naming. So having people really being able to even name, this is what is going on for me, this is what I'm experiencing, and be able to be kind of honest about their internal, what was coming up for them in the context of the work, has gone such a long way. And that is definitely something that you do not need to be a therapist to support someone in being able to do. Just being able to say, this is hard work. It's getting harder in many ways. Let's name that. And then this piece around building self-awareness, just the reflective dialogue, creating opportunities for people to really check in with themselves, what's coming up from themselves, what are they noticing, finding opportunities to have conversations around what is the work bringing up for people. Again, non-clinical people are able to have those conversations and facilitate those conversations, you know, even supporting leaders and being able to open a team meeting with some time to just reflect on what's coming up for the team can be so helpful. Yes, and so just the validation, the importance of validation as we are having these conversations about what can be challenging in the work can be so impactful. Staying curious, how is that approach working for you, for your patients? Slowing the pace down with sharing some of this content, really kind of giving people time to get to the place of being able to hear what it is that's being shared. Modeling openness, modeling vulnerability, modeling that it can be challenging to do the work, and that all that is coming up in the context of this work is normal, and that we are human. And all of those things go a really long way. And I love that just reminder that the learning happens when the nervous system feels safe.
I love that as well. All right, well, we are at 2 o'clock. So thank you so much. And I love this, that AD principles can be used to heighten provider self-awareness, team resilience, and reduce burnout. Again, we're so grateful to have you here, Nadezhda, and I know your colleague Denise is in the audience as well. We will be transitioning out. I'm glad we worked some Q&A right in. We've just had a 15-minute break, and up next is our final session of the day. It's featured presentations that are celebrating clinically diverse AD applications. So we're going to look at some of the topics that don't get as much attention as others, but certainly should. We will have a chat waterfall question for you. So hopefully you're all still alive and kicking and your brains are still working. And if not, just fake it till you make it. In the interim, I do want to say thank you for all of you who were very patient in trying to figure out how to access the breakouts. It is apparent that some of you whose professional Zoom accounts or professional emails are associated with a university, perhaps a state or local or federal government account, may have difficulty accessing those links tomorrow, the workaround is to use a personal Zoom account. So creating a really quick one with your Gmail, your whatever other email you may have that is not necessarily a VA account or a state of New Hampshire account, maybe the work through for tomorrow. Vishal is correct. It sounds like Zoom in Maryland is just being crabby. If you didn't have any problems, then you are blessed. And if you did, please again try tomorrow to use device. And Rocco and Dave, I'm going to put you on mute. Please try using a personal device or your personal account. That would be lovely. All right, so let's transition into some clinical diversity. Pop on over to the chat. What unique clinical topics would you like to see be the focus of a future AD initiative? Just curious, what do you feel like in terms of clinical topics doesn't get enough attention or should get a little more screen time in the AD realm? So even if you've seen it covered before, what do you want to see get more attention? Vishal says using AI within medicine. Oh my, that is terrifying, D3PO. What else? What else do we want to see get a little bit of attention clinically? How to avoid using AI in medicine. Medical cannabis. Yes, very interesting, Monica, for certain. And I know some folks have done that, but certainly could be looked at some more. I, for one, would love to see more about how to support patients who use illicit substances. So looking outside of prescribed opioids and so on. I know that that's taking off. PEP and PrEP for HIV prevention and DoxyPEP, adults, ADHD, lots of unanswered questions for frontline clinicians. Topics talked a lot about in the media. Yeah, would love to hear more, Victoria. Give us a couple examples. STI testing basics, maternal health topics. Yes, Narissa, I am right there with you. I, for one, would love to see a little more attention on perimenopause and menopause. I know that CEP did a wonderful bit on that a while back. Substance misuse and parents, geriatric addiction treatment, storytelling to help clients understand healthcare, solid vaccine evidence rather, and recreational cannabis yet again, menopause, PCOS, yes, polycystic ovarian syndrome, ovary syndrome, ADHD, obesity meds, geriatric polypharmacy, insomnia, postpartum OCD, and vaping. What a bunch of really cool topics here. And stimulants, of course. So let's go find the funding. Before we do that, let's go ahead and take a look at this wonderful deck that is about to come up from our fantastic colleague at CEP in Toronto, Silvana Ferrara. Over to Mike to officially kick off this session and introduce Silvana.
Fantastic. Thank you. Great to see you. And as Bevan said, appreciate everyone bearing with the various Zoom challenges. So it's been a fantastic first day, and it's not done yet. We have two featured presentations we're going to get in this session to give us important insights into how AD can be applied across a range of clinical areas. You know, both of these I can say, wearing my primary care doctor hat, are incredibly common topics in adult medicine, the first one in pediatric medicine as well, the second one in geriatric medicine as well, and that come up all the time, where clinicians really are struggling in different ways to understand what to do, and well-conceived and well-designed academic detailing approaches can make a huge difference. So our first feature presenter joins us from the Center for Effective Practice, or CEP, in Toronto. One of the mainstays of the academic detailing movement in Canada, another longtime NaRCAD ally. So Silvana Ferrara, who will be the presenter, she did her pharmacy training at the University of Toronto and has over 2 decades of experience out in the practice of pharmacy and community and long-term care settings. She's been an academic detailer with CEP for I think about 7 years now, working one-on-one with primary care physicians and nurse practitioners, really, really engaged in AD in the most pragmatic way. And so she's going to be talking to us about bridging knowledge and compassion, AD for obesity management, rooted in evidence and empathy. Very excited to hear from you, Silvana.
Thank you, Mike. Can I just bring you with me to introduce me at all my presentations? You make me sound so good.
My rates are very reasonable.
So let's get started. Bridging knowledge and compassion with academic detailing. I am going to get you to just visualize a scenario before we get started. So I want you to imagine you are a family physician in your office, and I want you to imagine that sitting right across from you is a patient with obesity. Now, this patient is someone who has tried every single diet imaginable. They have downloaded every diet app that's ever been recommended by any friend who said it worked for them. They've started and stopped numerous exercise programs, but no matter what they do, they just can't lose the weight. So as their physician, you start the conversation and you start off by asking them, can you tell me why you haven't been able to stay on that diet and exercise plan that we talked about a few months ago? And you go into stressing to them once again how, it's just really, you need to eat less, you need to move more, you just got to keep at it, you got to stay motivated, you just got to try a bit harder. Asking someone with obesity why they didn't stay on their diet and telling them to just try harder, that's not compassion. The patient feels judged, they feel discouraged, and they feel misunderstood. Now, imagine having a conversation with that patient where they leave feeling encouraged and respected. So having a conversation with that patient that's not only grounded in the latest evidence for obesity, but also in empathy. So what we're going to try to do in the next 20 or 25 minutes is take a look at how academic detailing can help bridge knowledge and compassion to help empower healthcare providers to deliver obesity care that truly makes a difference. So we're basically going to look at academic detailing with heart. So a little bit of housekeeping to start off with. I have absolutely no conflicts of interest to mention, but I do want to take a little bit of time to tell you a little bit about the wonderful organization that I'm very fortunate to work for, the Center for Effective Practice, also known as CEP for short. And CEP is based in Ontario, Canada. And as Mike mentioned, we're one of the largest independent, not-for-profit knowledge translation organizations for primary care in Canada. That's quite the mouthful. And as a not-for-profit organization, we do receive funding from the Ontario Ministry of Health. And CEP's main goal is really to help close the gap between evidence and practice for healthcare providers. And we do that by providing free evidence-informed clinical tools on a variety of topics. We currently have 40 clinical tools, I believe, and we also provide academic detailing, of course. So I want to tell you a little bit more about our academic detailing service. So our CEP's primary care academic detailing service was established in 2018. And based on how our government funding is structured, we're able to offer academic detailing to primary care physicians and primary care nurse practitioners. And our academic detailing visits are provided both virtually or in person, just depending on the preference and location of that healthcare provider. In addition to myself, our core academic detailing team at CEP consists of 4 other amazing detailers who are also pharmacists with varying backgrounds in pharmacy. And we also have our fabulous team manager, Victoria Burton, and our technical whiz and project coordinator, Brooklyn Reidner, and of course, our incredible and very knowledgeable multitasking queen, Trish Ron, who even though has a million things on the go all the time, seems to always have a smile on her face. So very, very fortunate to be working with these individuals. And we also partner with 4 family health teams in which the family health team pharmacist details the providers within their team. And in terms of our academic detailing program, each year we develop and launch 2 new clinical topics. And family physicians and nurse practitioners do earn 1 CME credit for each topic. And we usually have about 5 to 6 different topics on the go at one time. Next slide, please. So I'm going to take you back to last year, to 2024, when CP was trying to decide on, what is our next clinical topic going to be for our tool? What's our next academic detailing topic? And there were a lot of reasons why obesity was top of mind for the next topic. And at the time, and still today, weight loss medications are so trending on social media. It's really hard to be scrolling on your phone without an ad for a weight loss medication popping up, or the video of the latest actress who hasn't been seen in public for months, all of a sudden showing up on the red carpet with dramatic weight loss. And especially if you're a healthcare provider and you're around your dinner table with family and friends, someone's going to ask you about Ozempic. And oddly enough, everybody knows exactly what they are talking about. So needless to say, there was a lot of buzz about weight loss medications, and patients were hearing about these drugs. They were going to their family physicians, they were going to their family nurse practitioners and asking, hey, can you prescribe this for me? Also, what had happened in recent years, our knowledge and understanding for obesity had also changed. Obesity was now recognized as a chronic disease, and it was also acknowledged in guidelines as such. So since our knowledge of obesity had changed, the way we manage obesity also had to change. Compassion literally begins by acknowledging that obesity is a chronic disease and understanding that how we've treated obesity in the past, it didn't work. So this paradigm shift in the management for obesity was such a great opportunity for us as academic detailers to provide education to healthcare providers. And on top of that, there was new medications to treat obesity on the market. And although we had these new medications, we still weren't treating obesity as effectively as we could in primary care. Why was this? Lots of different reasons, things like treatment inertia, sticking with old beliefs that it really is as simple as calories in and calories out, stigma and bias around obesity, which we'll dive into a little bit more in a moment, and just limited comfort of experience among some providers. How do you prescribe these meds? What are the safety of these meds? And so to address all these challenges on the topic of obesity, CEP decided to develop a tool on pharmacotherapy for obesity management and the accompanying academic detailing. And given that obesity was such a complex topic, we decided to have more of a narrow scope for this tool, and hence why we're focused on pharmacotherapy for obesity, but while still acknowledging the importance for a comprehensive approach, including lifestyle modifications. So when we set out to develop these tools in our academic detailing program, we really wanted to design something that was going to support family doctors and nurse practitioners in managing obesity, not only more confidently, but also more compassionately. Because we really realize that how we talk to patients with obesity, it matters just as much as what treatment we're choosing from them. Next slide, please, Bevan. Okay, so I am going to ask you for your thoughts, and I'm going to ask you to do something really difficult, not filter the first thought that jumps into your head, which is going to be really difficult. This is a non-judgment zone. What I want you to imagine is that you're a clinician, you're in your favorite fast food restaurant, you're enjoying your nice hamburger and fries. You look up and you see a person with obesity walk in. What is your first unfiltered thought? It's going to be tricky. No judgment zone. Don't double check your thought. Whatever first comes to mind. Love the honesty. I love it. Very hard to do.
Would you like to read these or would you like me to?
Go ahead, Bevan.
All right, we've got they shouldn't eat here, you shouldn't be here, you should know better. Won't this make them worse? I guess they're here to have a good time. I'm going to pass on dessert. I hope they order a salad. My mind would be blank. They come here often. What are they going to order? Yeah, don't forget, this doesn't have to be what you think. This is if you were a clinician. Not that all
Exactly.
clinicians
Kind
think
of,
the same
right?
way. Yep, yep.
Makes,
We
makes
never,
it a little bit easier to step outside of yourself.
yes. And Donetta says nothing because you never know what someone else is going through. This is why we have a food crisis in this country. I'm done eating. Keep them coming, but back to you, Sylvan.
Yeah. Thanks, Bevan. So the truth is, we all have some type of bias towards a person with obesity. I have bias. We all have bias. It's almost an automatic thought that comes into our head. And it would take a whole other webinar to explain why that is. But the main thing is, most of us, when that thought comes into our head, we check ourselves so it doesn't lead to discrimination. And going back to that scenario of that individual with obesity walking into that fast food restaurant, we know nothing about them. They could have been 350 pounds last year and now they're 250 pounds. They may have originally went in there a year ago and ordered 3 hamburgers. They're now only ordering 1. So bias is something we really have to keep in mind. And what became really clear when we started to work on the development of this tool and training on the topic for academic detailing, it was really important for us, especially for this topic, to understand how bias, stigma, and discrimination was impacting patient care. And we had to understand it from both the provider's perspective. What happens when a provider has bias? How does it impact patient care? And looking at from it also from the patient perspective, what about that internalized bias that patient has? How does that affect patient care? And one thing we did from the very first webinar when we started training on this topic, the very first thing we did was look at understanding what is weight bias and understanding what it means. What's weight stigma? What is weight discrimination? And it was so disheartening to learn that 64% of adults with obesity report experiencing weight bias from a healthcare provider. And although it was disheartening, it really highlighted such a wonderful opportunity as academic detailers to make a difference in that area. So next slide, please, Bevan. So the next thing we looked at is, okay, if we do have a provider with bias, how does that impact patient care? And we learned that bias can translate into a lot of different ways. It can look like the patient comes in complaining of a symptom and they automatically just assume, well, it's got to be due to their weight. And they don't even consider looking at other sources for that symptom. It can be not spending as much time with that patient, having the mentality, oh my gosh, how many times have I told this patient what they need to do? They're not listening to me. I'm not going to waste my time. I'm not going to repeat this. It's using language that's condescending to the patient. So it can look like a lot of different things. Next slide, please. So just a quick little poll. Given that the data says that 64% of adults with obesity report experiencing weight bias from a healthcare provider, I'm curious if either yourself or someone close to you has ever faced weight bias or stigma in a healthcare. Just, yeah, exactly, yes, no, yes, no. From a quick glance, it looks like there's a lot of yes in the
Haven't
chat.
seen a single no yet.
Yeah, which is again very disheartening, but it does speak to the reality of what we're facing in primary care with patients' experience in obesity. So while people continue to type, I think we'll go right to the next slide, Bevan. That's wonderful. So having a better understanding how provider bias affects that patient care, the next thing we had to do is, well, let's look at it from the patient's perspective. So we knew we had to involve people with lived experience in tool development. And although people with lived experience have been involved in tool development in the past, this was the very first topic where we actually had people with lived experience come and talk to the detailers. So during that very first webinar that we started our training on academic detailing, individuals with lived experience were invited to the webinar. We had a chance to have conversations with these individuals. They were so gracious, so generous with their feedback, and we were just so appreciative that, I mean, it's so vulnerable to have those conversations, and the fact that they were willing to help us understand what they experienced. So what you're seeing here are actual quotes from some of those people with lived experience that we converse with during our webinar. And you can see some of the kind of the highlighted points there. Like one individual said, you know, it definitely has an impact on my confidence and self-esteem, mentioning that everyone deserves respectful treatment and to be treated with the same dignity. And also comments in terms of, you know, my ability to do this work and that it's worth it, and then I'm worth it. And even the feedback saying that, you know what, because I have so much negative self-talk, I really value that encouragement from my healthcare provider, which again, it just gave us so much more insight of, okay, well, here's another opportunity that we can use academic detailing to help providers realize that everything they do, from the environment they create in their office, the language they use, it all affects patient care. Next slide, please, Bevan. Another quick little poll. So in Ontario, we currently have 5 medications that are approved and indicated for obesity treatment. Now, I know you're not all from Ontario, so it's okay to guess. So given that obesity is now considered a chronic disease, how many of the 5 drugs do you think are covered by our provincial drug plan? Guessing is totally allowed. Okay, so we've got 2, 5, 1, got some zeros in there. Yeah, so definitely on the lower end, seems to be trending on the lower end with that. So I'll let you go to the next slide, please, Bevan. So the sad answer is that although obesity is now acknowledged as a chronic disease, there is not one single medication that is covered by our provincial plan. And when we looked into private drug coverage, it was only about 25% of plans that were offering coverage for obesity medications. And when I tried to stop and think of any other chronic disease that doesn't have at least one medication covered on our provincial plan, it was hard to come up with another chronic disease that doesn't have at least one drug covered. And so we knew this was going to be a huge barrier in terms of access, and it really posed a unique challenge. So we had this systemic barrier that obviously it was a barrier to equitable care and a potential indicator even of maybe some implicit bias of our funding system. So it was another real barrier that we had to address. And the other thing was these medications were not cheap. The most commonly prescribed obesity medications are a family of drugs called GLP-1s, and a 3-month supply ranged from anything from $1,250 to over $2,600. And you know, sometimes you look at this and they're just numbers. But then when you talk to someone, I was talking literally to a friend of mine a couple of nights ago. She has a daughter and son that are both in university right now. Anyone who's had kids in university knows how expensive that is to begin with. And her son's 19 years old. He has obesity. It's affecting his self-confidence. It's affecting his self-esteem. They have private coverage. It's not covered. And so she's really struggling because I can't even imagine as a parent seeing your child struggling with something like that. You can't afford the medication. So it's real, it's happening there, and it's really impacting patients' lives. Next slide, please. So as I mentioned earlier, one of our goals of developing our clinical tool for this topic in academic detailing was to bridge the knowledge and compassion. And the first thing we had to do, well, we had to bridge the knowledge gaps. So how did we do that? Well, luckily at CEP, in addition to our academic detailing team, we also have a fabulous tool development team. So when I say our team, I am not referring to just the academic detailing team. I am referring to our tool development team. But our team did conduct a comprehensive literature review, and we looked at the current guidelines and existing resources and identified what practice gaps were out there for obesity management. And with that, we landed on 3 key messages. Our first key message was really focusing on that comprehensive assessment of overweight and obesity and letting the patients know, what are their goals, using shared decision making. Our second key message was really focusing on the medications for obesity. How do we choose these medications? And then the third key message was focusing on, well, what happens once we prescribe these medications to these patients? What do we do then? How do we monitor? How do we have those conversations and have patients understand that this is a chronic disease? This might be something you may have to be on for lifelong, but then also bring into the picture that can you afford to stay on these medications lifelong? So lots of barriers in there. Next slide, please. So when it came to developing our tool, our team did develop our pharmacotherapy for obesity management tool. Again, we did have topic expert groups that also helped to shape the tool. So we had the topic expert group that included family physicians, nurse practitioners, of course, individuals with lived experience, and the academic detailers also had opportunities throughout the developmental process to give feedback. And then in terms of our academic detailing training, really we had the chance to do a deep dive into the literature, the guidelines. We had several webinars that focused on each key message. And then that all culminated in a 2-day in-person workshop that was co-led by a family physician lead and our clinical director, Trish. And for every topic, we always have a family physician lead who has a family practice, but tends to have their practice with a little bit more of a focus on the topic that we are addressing. And the physician lead is so invaluable to us because they really paint the picture of the landscape in primary care. What are the barriers we're going to face? What are the frustrations providers are going to face? And it really gives us a feel for what is happening in primary care. And then in October 2024, all that hard work paid off, and we launched our clinical tool on obesity, and we also launched our academic detailing topic on obesity. Next slide, please. So as I mentioned, we obviously focused on the evidence for obesity, but we also had to make sure we addressed weight bias and stigma within the tool. And in fact, if you ever have a chance to just navigate to the cep.health website and you bring up our clinical tool for obesity, the very first thing on top of that tool, you're going to see this little box that says important considerations for primary care clinicians. And when you click on that box, it really focuses on weight bias and stigma. And we really encourage clinicians to self-reflect on their own bias that they may have. We ask them to consider things in their office. Is their office a space that feels respectful to someone with obesity? We ask them to reflect on their languages that they're using when speaking with patients with obesity. Next slide, please.
And that management tool, obesity management tool, is just in the chat box now. If
Oh,
anyone wants
perfect.
to take a poke at
Thank you,
it.
Bevan.
Sure.
Amazing. Thank you. And so, of course, if we are going to encourage them to think about addressing weight bias and stigma, we also have to provide tools that they can actually do that by. So within our tool, again, we have certain resources like the Harvard Implicit Test, which helps them to identify, do they have weight bias? How is it affecting their actions? We also encourage them to use non-judgmental language. Do not refer to them as an obese patient. They are a patient with obesity, and it changes the tone with that. We also encourage them to create a weight-friendly practice. That very moment that patient steps into their office speaks volumes. They're entering the waiting room. Is there a chair that they feel comfortable sitting in? Is there a chair that when they look at it, they're not thinking, I'm going to stand because I don't think it holds my weight? It starts right from the time they enter that office. Providing extra large size gowns, having a scale that if you ask that patient to step on the scale, it's actually going to register over 350 pounds. and having things like larger cuffs to take blood pressure. All that matters because it sends the message to the patient. You took the time to make sure that they were going to be comfortable in your office, and that makes them feel respected. And another tool we included, which is called the 5A's approach, which is basically a step-by-step assessment of obesity and leading them right through to treatment. But the very first thing in that particular 5A's is asking for permission to talk about their weight. And that is really, really important because you know what? If that patient came into you and they're just asking to renew their prescription today, they might not feel like talking about their weight. So at least if you ask for permission and if they say no, well, you document it in the chart, you try to bring the conversation up the next time. But again, we're creating respect for that patient. Next slide, please, Bevan. So jump forward to now, the present time. So now this our pharmacotherapy for obesity management tool and detailing service has been out for a little bit more than a year, and we do still offer detailing on this particular topic. So what was really interesting for this topic for us, it had the most rapid uptake of any topic we've ever done since before COVID-19. When we sent those recruitment emails out to sign up, usually you get your standard few signing up and then some dribble in. We got a lot of uptake for signups right away, which was amazing. And even a year after, we're still getting signups for this topic. So these stats were from the end of October. So in terms of academic detailing visits, we've had almost 300 visits on this topic, visited almost 400 clinicians. We spent an average time of 40 minutes during our visits. And in terms of the tool downloads, we had about 4,500 downloads. Next slide, please, Bevan. So what did we learn from this topic? So we definitely learned that there is a lot of barriers that came with detailing on this topic. Having the fact that none of these medications were covered on the provincial plan and only a few were covered on private plans, huge barrier. Also, unrealistic patient expectations. They're seeing and getting all this information from social media, and the impression they were getting is, I just have to go into my doctor, get this prescription, stay on it for a few months, lose the weight, come off of it, and life is good. And we know that's not the case. We know that these medications, according to the trials, when patients stop these medications, the majority regain the weight. Medication side effects, physicians were asking, the GLP-1s, which are the most commonly prescribed, they have side effects. They're not pleasant. How do I cancel patients on these side effects? How do I minimize these side effects? And again, just dealing with that internalized weight bias that patients may have and dealing with the biases that providers have. So again, we just made sure to include resources in the tool that helped to overcome these barriers. So we looked into, are there any cost-saving programs out there? The answer was yes. Were they the greatest? No, but they did offer some financial relief to some patients. We actually did create a patient handout for the GLP-1 class of medications. Providers were saying, it takes a long time to counsel on these medications. So we did provide a handout that they can start the conversation, give the patient the handout, and then the patient can always come back with any questions. Next slide, please. So looking forward, what did we learn? So we definitely learned that the topic of obesity had so many layers of bias and stigma from the provider perspective, the patient perspective, system perspective. And we just learned that it really reinforces the critical role of academic detailing, not only in translating evidence, but also translating evidence into a compassionate practice. And that combined with empathy and behavior change really, really can make a positive impact. And it also underscored the importance of integrating people with lived experience in the development, not only our primary care resources, but also within our academic detailing. So we'll definitely continue to do that in the future. And the last thing was too, this is one of the first tools that we decided to do more of a narrow scope. And we learned that even though it was a narrow scope, it was still very well received. So that just lets us know that in the future, we can also approach future tools with a more narrow scope. And that is it.
Thank you so much, Silvana. We have time for a couple of questions. Really appreciate the thoroughness with which you and CEP dove into this. So we have a question from Jessica. Did you have any strategies to share with providers to address the misinformation patients are seeing in the media, direct to consumer advertising?
So it definitely was honestly a visit opener a lot of times in terms of, do you find, are you having patients come to you asking about these medications, or are you finding it's you that is initiating the conversation? And for the majority of the time, it was no, patients are coming to me in terms of asking about these medications because they're seeing it on social media. In terms of helping to kind of demystify, so to speak, the misinformation that patients were receiving, a lot of it started with us providing the most up-to-date evidence for those clinicians and having them understand that, obesity is now a chronic disease, having them understand that what we've learned from the clinical trials from these medications is that it looks like this might have to be a lifelong treatment for patients. So we emphasize the importance that when you're having that conversation with the patient, let's make sure they understand this. This is not going to be a medication they can use for a few months and then have the weight come off and never think about it. So it was really providing the education to the physicians and then having the physicians provide that education to the patients. So a lot of the questions that we got was, well, how long do patients need to stay on these medications? What happens when patients come off these medications? Is there a difference if I taper the drug off or I stop cold turkey? A lot of it had to do really just with educating the provider first, and then having that provider realize that even before you pick up that prescription pad to prescribe this medication, really make sure the patient understands what they're getting into, which was interesting because one of the conversations that came out of our conversations with people with lived experience is one of the individuals said, if I had known what it would be like to start this medication, I may have not started it, because she was under the impression that she could just use it for a few months and then stop. And had she known it could potentially be a lifelong commitment, she would have thought twice. So that was very interesting as well. But we just tried to provide that education during the academic detailing visit, and hopefully that was relayed to the patient as well.
Thank you so much, Silvana. Unfortunately, we are running really low on time, but it does look like the amazing folks in Canada are responding to questions that are coming up in the chat and doing a tag.
I have a fabulous team
of answering those. Mike, I know you have a question. Can you keep it brief?
Absolutely. Super, Silvana, wonderful session. Super quick question. I'm interested, I wonder if CEP, especially if the medications continue to be difficult to get available, would think about, in addition to the detailing campaign on how to treat obesity, a detailing campaign on treating patients with obesity, because I think, as you pointed out, so often they don't get their blood pressure or their diabetes or their high cholesterol optimized, where there might be an assumption, oh, it's just their weight, and this sort of this healthy at any weight idea. So could there be a room for another initiative on giving the right treatments to patients with obesity?
Oh, that's a great question, Mike. I am definitely not high enough on the totem pole to make that call at CEP. I don't know if any of my wonderful team members who have a little bit more clout than I do, but I think it's a great question. Whether that will happen, I'm not too sure. But I guess if we had all the funding. Oh, I hear a voice.
Sorry, that was me saying we'll have to follow up and see. And Jerry says, let's hope that Novo patient shenanigans don't delay the availability of generics when the time comes. Well, thank you so much. And thank you again for the amazing folks at CEP. You really do have such a wonderful team of colleagues, patent, not patient, patent. You have such a wonderful team of colleagues who are supporting each other. And, we really always love to hear from you. Thank you again for speaking on this very important topic. Okay, we'll be moving on to our final presentation of the day. Mike, over to you to introduce the detailed team. Actually, but first we have a quick chat waterfall. What's one of the top challenges clinicians face when caring for patients with dementia? What would you say is the number one thing that comes to your mind? Pop that into the chat box. Disengaged family members that are tired. Yes, caring for the patient's caregiver, support services for the family, communication, more for caregiver support. Yep, that's a big one. How do you align with them? Let's get a couple more in there. Yep, lack of treatment options. Do you talk with the patient or do you need to talk with the caregiver who may or may not be very accessible or involved? Understanding the patient's needs, the progressive nature of the disease, apathy. Yeah, good one, Adrian. Lack of community knowledge, coordinating care, poor historians, treatment expectations, and family members to align ACP end of life care as well. These are all very important considerations. And I'm going to turn it to Mike to introduce Art and Tammy of the Wisconsin Alzheimer's Institute to speak more to this. And thank you everyone for adding a few more thoughts into the chat. Over to you, Mike.
Absolutely, yes, a really appropriate topic for our final formal presentation here on day one. So this is from our colleagues at the Wisconsin Alzheimer's Institute, as the chat waterfall made clear, talking about AD for dementia. And this is something that's becoming more and more prevalent, affecting families and communities everywhere in the world. So let me introduce our presenting pair here. First, I'll start with Tammy Albrecht. She's a board-certified adult and geriatric primary care nurse practitioner. She's a public health educator at the Wisconsin Alzheimer's Institute, and she designs and delivers their educational programming to clinicians caring for patients with dementia. She's got prior frontline experience as a nurse case manager in home health care, and really is committed to that multidisciplinary approach, that sort of network of allied professions that we talked about this morning. And Tammy's going to be joined in the presentation by Dr. Art Walizek. He's a board-certified geriatric psychiatrist and a professor of psychiatry and medicine at the University of Wisconsin School of Medicine and Public Health. He's also Associate Dean for Faculty Affairs and Development at the School of Medicine and Public Health. He's had multiple national leadership roles, currently works with the Wisconsin Alzheimer's Disease Research Center as co-leader of the outreach, recruitment, and education care, and with the Wisconsin Alzheimer's Institute, as we talked about. He remains active as a clinician, educator, and researcher, as well as author and editor of multiple books. So Tammy and Art will be teaching us about detailed and dementia educational techniques. Over to the two of you to bring us home for day one.
Thank you so much. So I'll kick things off and then I'll hand things off to Tammy. Mike, appreciate that very gracious introduction. Bevan, thank you for your fantastic communication and coordination of all this. And Silvana, thank you for setting the bar incredibly high. That was an incredible presentation, and I hope we can keep our audience equally captivated here as we talk about academic detailing in the context of dementia. I'm a little embarrassed to share, every time I saw AD, like in the materials, I'm like, oh, Alzheimer's disease, that's great. But you all mean academic detailing. And so I think it's just meant to be, actually, that we would apply academic detailing to the care of people with Alzheimer's disease, which is the most common cause of dementia. Quick disclosures here. So I get some royalties from American Psychiatric Association Publishing. Tammy doesn't have any disclosures. Our funding sources, and this will come up later, but our funding sources are the now extinct U.S. Administration for Community Living, which kicked us off several years ago. Two intramural funding mechanisms here at the University of Wisconsin in Madison, and the Geriatric Workforce Enhancement Program. We have a lovely multi-site project involving Marquette University in Milwaukee, their School of Nursing, plus our School of Nursing, plus RVA, plus the Wisconsin Alzheimer's Institute. So it's a really, really cool project. here's our team. So we have an amazing team of folks. So Tammy, you'll hear from later. She's our public health educator and expert in academic detailing, and she's been our tie to NARCAD, and so I've tremendously appreciated her for that. Molly Schrader is our outreach programs manager and kind of keeps everything running, and also is a content expert in an approach called DICE, which stands for Describe, Investigate, Create, Evaluate, which are the steps in addressing behavioral and psychological symptoms of dementia, which we'll get into more in a moment. Tammy LeCaire is our amazing scientist who kind of makes sure that what we're doing is scientifically rigorous and also sets us up for our grant success. And Jenny Vidal is the newest member of our team, a data manager and analyst, and also helping us with some of our work in terms of outreach to Spanish-speaking people with dementia and their caregivers. Next slide, please. Okay, so what are we talking about here? We are talking about behavioral and psychological symptoms of dementia. So first of all, dementia, as you all know, is an umbrella term that covers acquired progressive illnesses that affect cognition and functioning, like driving and cooking and money management, and then personal functioning like hygiene and ambulating and toileting and so on. However, the vast majority of people with dementia also experience behavioral and psychological symptoms. So I was delighted to see someone put apathy in the chat, because that actually is, in fact, the most common behavioral and psychological symptom of dementia, especially as the illness progresses. Aggression and agitation are particularly dangerous and problematic manifestations of dementia, and can lead to safety issues for patients, for caregivers, for other residents of assisted living or skilled nursing facilities where people reside. Psychosis can be particularly disturbing both to persons living with dementia and their caregivers. Sleep disturbance is a huge issue. A lot of you talked about caregivers, which is a huge focus of ours as well. And, a caregiver can at least hopefully look forward to a few hours of sleep at night, except when they can't because the person is up at night because they're agitated or screaming or falling out of bed or wandering out of the house. So there are other BPSD, but those are some of the most common and problematic ones. So ideally, there would be squadrons of geriatric psychiatrists like me who could just sort of parachute in and help address these situations. In the US, there are probably no more than 1,500 geriatric psychiatrists for a population of 360 million. So that's not really a viable solution. Geriatric medicine doctors, there are more geriatricians. They're really good at this stuff as well, but again, not really a lot and often maldistributed. And so it often falls on primary care providers to address the initial evaluation of dementia and then the management, including behavioral and psychological symptoms of dementia. In our work, we found that PCPs are often interested in learning more about how to care for people with BPSD, but often sort of lack the training and the resources, the skills to address these issues. And that was really the impetus for our program. Next slide, please. Which is called DETAILED. So DETAILED is an acronym that stands for Dementia Educational Techniques, Academic Detailing, and DICE. So we marry, and in our latest incarnation, there's a third component to this as well that includes tools to be used within the electronic health record, specifically clinical decision support tools. So that plus academic detailing and DICE makes up this package of detail that we have implemented in primary care settings. So the focus is on educating primary care providers and their staff. So not just the PCPs, because it's nursing staff, it's front desk staff, it's social workers who are also addressing BPSD, either directly in the patients or in their family members or other caregivers. Our focus is on assessment, really kind of understanding what BPSD are about, and there are kind of different models for that. and especially on non-pharmacological management or behavioral approaches, environmental approaches, psychological approaches. We're kind of toying with relabeling that holistic approaches to dementia care. And if at all possible, avoiding medications, although there are some settings in particular when there's dangerousness or safety problems involved where medications might be appropriate. And then as part of academic detailing, we share information with the primary care providers around what might be appropriate interventions and how to think through risk and benefit of those interventions. Next slide, please. So this is just a sample of the tool that we use. So we've implemented this in a variety of different ways. One approach has been to simply to come in with some didactic content that either we've identified ahead of time as potentially helpful, or that we're with our primary care partners, they've identified topics that they'd like to hear about, and then we develop some content for them. And then we do some case discussion. This is a guide that helps the clinician think through how to be best prepared for our academic detailing, and then we go through case discussion with them. And the idea is, again, the model here is because there are not enough geriatric psychiatrists or geriatric nurse practitioners to go around, that we would empower the primary care clinicians to kind of think like we do in terms of addressing behavioral and psychological symptoms of dementia. Next slide, please. Okay, this is our initial pilot that we got funding for through the Wisconsin Partnership Program, which is an intramural funding mechanism. We had done work before with an element of detailed called DICE. That was the funding through the U.S. Administration on Community Living. We had trained around the state of Wisconsin a number of social services professionals called dementia care specialists. We had trained them in the DICE approach. So that was our very first grant. That grant had other components as well that are not directly relevant here. The second grant was to pilot this. And so we went to 2 primary care clinics that also had a strong memory component, one in an urban setting in Milwaukee and the other in a rural setting about an hour and a half northwest of Madison. And this is our first go round of grant funded academic detailing. And so we envision this kind of tapering off schedule of 6 monthly visits, then 3 every other month visits, then 2 visits every 3 months. Using that format that I mentioned earlier, some sort of topic that we would briefly cover, case discussion, and then determination of future topics. So next slide, please. We did collect some data. So again, this is grant funded, and we needed to demonstrate outcomes. We want to demonstrate outcomes anyway, because we want to be able to scale this up, which is some of our ongoing grant writing efforts. So in this approach, we asked questions of our primary care colleagues around the acceptability of the tool. We had a 10-item knowledge assessment. And then we used a validated scale called the GPACS, the General Practitioner's Attitude and Confidence Scale for dementia, to help measure some of the attitudinal aspect of this intervention. So next slide, please. So here are some of the results. So very small ends here, but despite the small ends, we were able to demonstrate some statistically significant, and I do think educationally significant changes as well. So on this 10-item knowledge score, the baseline mean score was 5.2, went up to 7.2, so a 2-point increase in score, and that was statistically significant. The GPACS-D, so that's this General Practitioner's Attitude and Confidence Scale for dementia. It has 3 subscales: confidence, attitude to care, fears and frustrations. And so on one of those, we were able to demonstrate a statistically significant increase, but not in the other attitude scales. Next slide, please. There we go. And then in terms of acceptability, this is just a simple Likert scale from strongly disagree to strongly agree. Academic detailing approach was acceptable, so the vast majority is strongly agreed or agreed. I'll apply what I learned. Again, vast majority strongly agreed or agreed. And same for I will recommend the academic detailing model. So I'm going to pivot over to my colleague Tammy Albrecht. Just by way of context, I just want to add. So in terms of grant writing to fund further exploration of academic detailing, what we kind of came to two realizations. One is, especially looking at NIH funding, they understandably are very interested in mechanism. So not just does the thing work, but how exactly does it work? And what are the components of it that make it work? And so that's been a bit of an adventure for us, kind of thinking, I'm a clinician at heart. I'm a very pragmatic person. Like, if it works, great. If it doesn't, try the next thing. But that doesn't fly in terms of NIH grant funding, it turns out. And so we've had to think a lot about mechanisms in terms of including like how exactly might academic detailing change people's behavior, skills, attitudes, and knowledge base. And then we've gone back and forth between thinking of this as an educational intervention and also dissemination and implementation research. And so we've had to kind of get into that literature, and that's where this REAIM PRISM model idea comes in. And Tammy, I'm sorry, I didn't mean to steal any of your fire, but I wanted to just kind of set that up as to like, why are we talking about this exactly? And so Tammy, I'm going to hand things over to you.
Thank you very much, Art. So following the pilot program, we decided to take a deeper dive into the educational needs of primary care providers in Wisconsin related to the management of BPSD. The goal for this study was to identify facilitators and barriers to implementing academic detailing for BPSD in primary care with the intention of refining our program and informing future delivery of the detailed model in additional primary care settings. This figure on the slide depicts application of the REAIM PRISM framework, which guided our qualitative study. Following this framework, we conducted qualitative interviews and analysis to consider the factors that would impact the reach of our program for primary care clinicians, the adoption or participation in the program, the implementation or application of the program, including program characteristics and strategies, as well as uptake of key messages and recommendations shared during our sessions, and the effectiveness of the program, in which we focused on knowledge and self-efficacy in managing BPSD in primary care. During analysis of the interviews, we also focused on PRISM contextual factors, such as organizational, clinic, clinician, and patient and caregiver level factors. Next slide, Bevan.
Okay,
Thank you. So we conducted semi-structured qualitative interviews that took about 30 to 45 minutes. Interviews were recorded on the Zoom platform with consent. One team member updated transcripts using audio recordings. Interview guide questions were based on the REAIM PRISM framework that we just discussed. Participants were clinicians from the two pilot programs. And then clinicians referred to as program champions were those who encouraged others to participate in detailed, supported implementation by bringing cases or discussion, and participated in half or more of the previous pilot academic detailing sessions. Clinicians with little to no academic detailing experience were categorized as program novices. Following the interviews, we analyzed the transcripts for themes. 4 team members reviewed interview content, identified themes, and discussed themes to reach agreement. We used an inductive approach in which we allowed themes to emerge from the content of the transcripts. This allowed for unique themes to be captured, keeping the needs and perspectives of the clinicians at the center of our findings. We also used a deductive approach in which we organized themes by multi-level PRISM, internal and external contextual factors. Again, those were organizational, clinician, clinic, patient, and caregiver levels. Here's a sample of our interview guide. We developed interview questions that address specific domains within the REAIM framework, specifically focusing on reach, adoption, implementation, and effectiveness. For example, we inquired about adoption of the program by asking champions the question, considering your organization, clinic, and team, what factors influenced your participation in academic detailing? Overall, our questions were geared towards exploring gaps and needs in managing BPSD, as well as barriers and facilitators for implementing detailed. Because we interviewed clinicians with varying levels of experience with our program, we developed two different yet similar guides to capture the unique needs and perspectives of the champions and novices. We interviewed 14 clinicians who practiced in family medicine, internal medicine, and behavioral health. Participants included 7 champions who had previously participated in our program, and then 7 novices who had little to no experience with our program. So following a thorough analysis of our interviews, we found 11 themes related to clinician level factors. They're listed here. I might not read them all just for the sake of time, but we're going to go into greater detail in some of them on the next slides so you can see how these themes emerged from our interviews. So first, we have the theme of self-efficacy in management of BPSD. So this theme emerged from clinicians reporting low self-efficacy in identifying BPSD triggers, managing complex symptoms like agitation, and confidently prescribing medications. Champions reported detailed as being effective in addressing low self-efficacy by improving the recognition of BPSD, strengthening non-pharmacological strategies or holistic strategies, as we mentioned, and supporting safe and effective medication use. These are quotes from champions who described the effectiveness of detailed on knowledge and confidence in managing BPSD. We can see that a clinician said, I think it makes me feel less frustrated and it gives me a sense of how to negotiate with the family and the supports. Getting the comfort level was important to me. I'm a little bit more comfortable with the medications that I previously wasn't, and I've been able to incorporate those a little bit more into practice when needed. The next theme that I'll talk about is educational intervention philosophy. This emerged from clinicians highlighting tailored learning, interdisciplinary training, and co-learning that occurs during the academic detailing sessions. Clinicians mentioned the importance of topics being relevant to their clinical practice, thinking about their patients and the needs of their patients. Champions valued modeling of communication, workup, and decision-making by the academic detailers through case discussions. Clinicians also mentioned the benefit of including additional team members, such as nurses and medical assistants in future trainings. They reinforced the importance of collaboration when caring for patients with dementia. It's not just the provider, there is an entire team involved, from the patient and caregiver to the receptionist, to the nurse triaging calls, and to the provider facilitating management. They also shared the benefit of a team-based approach or team-based sessions because they were able to learn from each other. Here are some quotes from our participants again regarding the educational intervention philosophy. The first 2 quotes highlight the value of knowledge that can be gained from the academic detailing sessions, including key messages on workup, diagnosis, and interventions. Next, we have the theme of learning culture and values. So this theme emerged when clinicians mentioned their desire to improve the quality of care they provide and their commitment to their patients and communities they serve. Novices mentioned a desire to stay current on the latest evidence and provide the best possible care. Champions mentioned a desire to address complex care needs of aging patients with chronic conditions and support families to avoid facility placement due to behavioral issues. Both champions and novices were motivated by their desire to expand their knowledge in dementia care, recognizing not everything can be learned during medical school and residency. During interviews, we heard about the positive impact of an environment that supports continuous learning and seeing colleagues participating. Here we have some quotes describing the learning culture and values. We heard things like every day is a new learning experience, describing the program as invaluable, and speaking to how they used what was shared during the academic detailing sessions, specifically how to ask about sensitive topics such as hallucinations to improve their practice. And then we had the theme of time and scheduling constraints. This was a universal concern among champions and novices. Clinicians emphasized that the ability to participate requires consistent scheduling, having flexibility in how academic detailing is offered, such as virtual sessions, which allowed for reduced travel time, ability to join from their offices. Clinicians also reported that time constraints impact their clinical practice, their ability to adequately identify BPSD and develop care plans for their patients. Here are just a couple of quotes regarding the format and scheduling of our sessions. The case presentation, a lot of people thought that that was helpful, one stating that was just tremendously beneficial for me because that just kind of makes it real life. Key takeaways from our interviews include improving self-efficacy through tailored applied education is central to our impact on clinical practice, especially for managing complex BPSD cases. Our program success is rooted in interactive, practical, interdisciplinary learning aligned with real-world clinical needs. A strong internal drive, peer influence, and commitment to patient-centered care was central to clinician engagement and academic detailing. And effective implementation requires built-in time and flexible delivery formats tailored to the clinician. And then I will send it back over to Art to talk about our next steps.
Tammy, thank you so much. Greatly appreciate that deep dive in some of the qualitative outcomes that we got as a result. So we continue. Thanks for the great questions in the chat around funding mechanisms. We're continuing to pursue the NIH route. We have a revision of an R21 due in the next few days. We've all been furiously working on that. The goal of that project is to so the academic detailing we've done thus far have been in primary care clinics with a strong memory emphasis, and there's sort of a backstory behind that I'd be happy to share. Now we want to kind of try this in like true primary care settings. So that's next. And then hopefully with that being funded, then we can scale up. And then I mentioned in the chat that we probably aren't ready for PCORI because we don't have, for this particular intervention, evidence of clinical efficacy. All of our measures have really had to do with process and with the providers themselves, and not so much with patients or caregivers. So I would very, very, very much love to do that and look at a healthcare utilization and so on. So that would require a much larger, we envision multi-site step wedge design, randomized control trial to do that. So that's some of the future. In the meantime, we continue. We have through that GWEP mechanism I mentioned, we're doing academic detailing with a couple of other sites, including one that serves primarily a Spanish-speaking population, which is very exciting in terms of adapting this approach to another population that might otherwise may have difficulty with access to it. So thank you very, very much for this opportunity, and look forward to your questions.
Thank you so much, Art and Tammy, and wonderful to have your other team members here. Lots of amazing questions in the chat. That Art, you were flying with your answers over there, and really appreciate the robust conversation with Jerry and Mike and Sally and everybody else who dove in on the chat. If you missed any of it, please do scan. We have time for one more question from Aaron. What background, education, and clinical experience did your detailers have? MDs, RNs, pharmacists, etc. Oh, and looks like Art already answered. Our detailers are Tammy and yourself. So a DNP and an MD. Wonderful, wonderful breadth there. And if there are any more questions for Art and Tammy, please pop them in the chat and they will hopefully be able to answer via chat. But for now, it is time to bring day one to a close. I want to say thank you to all of you for being part of a wonderful day one. Really fantastic breadth of content, really wonderful engagement from all of you in the audience, which really makes or breaks a day like this. Thank you again for all of you who presented today and for those of you coming tomorrow. As both attendees and speakers, you are in for a real treat. So please do check out tomorrow's agenda. But for now, for these final couple of moments, we have a 3-minute survey. If you can tell us what worked today and what didn't. It is anonymous unless you would like to put your name. It is a wrap. You can click on the link in the chat box, or you can use your phone and you can scan the QR code right there on the screen. But once you have that bad boy open, we want to wish you good night and thank you so much. And I will again pop the link in the chat so it's right there for you. If you have any needs, concerns, questions, please stay on and Mike and I will be happy to help you. But otherwise, we appreciate you all so much. Have a wonderful evening and we'll see you tomorrow at 11 Eastern. Take care.
Be sure to do your evals.
Thank you. Appreciate you.
Bevan, Art wants to know where we are on the socials because you know that I'm ignorant about this.
Oh, Art, we
are
are
Blue Sky was the
we
question.
are not on Blue Sky. No, we are still on X, but I do not post there to stick it to the man. So we are nowhere. We are nowhere and everywhere.
Come to Blue Sky. It's very pleasant.
Okay, we'll think about that. We've also heard Threads is a wonderful space to be.
Yeah, another good option. Yes.
Wonderful. Well, thank you so much. Take care, everyone. And yes, as NaRCA said from Chicago, if you can check out the Northern Lights tonight, it's supposed to be the brightest that it's ever been. And I've seen pictures from folks in the city of Boston last night who got wonderful shots of it between 10 p.m. and 3 a.m. So if you want to party tonight and check out the lights, we look forward to seeing pictures tomorrow.